Good morning and welcome to the first meeting of the Health, Social Care and Sport Committee in 2025. I've received apologies for this meeting from Elena Whittam. The first item on our agenda is to consider a consent notification sent by the Scottish Government on the Food and Feed Regulated Products Amendment, Revocation, Consequential and Transitional Provision Regulations 2025 RP Reform SI. This is a UK statutory instrument where the UK Government is seeking. The committee's role is to decide whether it agrees with the Scottish Government's proposal to consent to the UK Government making these regulations within devolved competence and in the manner that the UK Government has indicated to the Scottish Government. If members are content for the consent to be given, the committee will write to the Scottish Government accordingly. Here we will also have the option to pose questions or suggestions or to ask to be kept up to date on relevant developments. However, if the committee is not content with the proposal, it may make one of 3 recommendations outlined in paragraph 13 of the Clerk's note. In advance of today's meeting, I wrote to the Minister for Public Health and Women's Health on behalf of the committee with a series of questions related to the instrument. The Minister submitted a letter in response on Friday the 10th of January, and both letters are annexed to the public paper for this agenda item. Further to this letter, members may have further questions they wish to put to the Minister about the instrument. If that is the case, the committee could decide to invite the Minister to attend its next meeting on Tuesday the 21st of January. In that case, the committee would defer a final decision on the instrument until after it is taken further evidence from the Minister at that meeting. Does any member have any comments they wish to make? Gillian Mackay.
Thanks, Convener. I would be in favour of deferring the decision to next week after we've taken some more evidence, some concerns around the capacity of the FSS and FSA to continually review the evidence as set out in the proposal, alongside a few other issues as well that I think it'd be useful to explore with the Minister and potentially with Food Standards Scotland as well.
Thank you. Anyone else wish to? Emma Harper.
Thanks, Convener. Good morning, everybody. Like Gillian Mackay, I would be interested in deferring it. I have got long-standing interest in food additives and how food is processed. Ultra-high processing does mean that additives and stabilisers, emulsifiers and lots of different things are added to food. And I'd be interested in just finding out more detail in order to see where we can go regarding this statutory instrument.
Thank you. Joe Fitzpatrick, do you want to put
thanks. I think it's absolutely appropriate that we hear from the Minister. It's really a very technical instrument, so I think it would be helpful to hear from the Minister, but also from Food Standards Scotland, please.
Okay. Brian Whittle.
Well, I think that we've looked at this over the piece for a number of years actually, and generally speaking, I think the standards in which UK are held to or hold themselves to is probably not as high as I would like it to be, but tends to be higher than a lot of the EU. However, it would be appropriate to double check and make sure that is still the case. And as the colleagues have said, I think it's appropriate to defer.
Thanks. I therefore put it to members that will invite the Minister for Public Health and Women's Health to attend the committee's next meeting on Tuesday the 21st of January to answer further questions on the instrument. Are we agreed? Thank you. We are agreed. So we'll write to the Scottish Government to that effect. The next item on our agenda is to take evidence from 2 panels of witnesses as part of our scrutiny of the Assisted Dying for Terminally Ill Adults Scotland Bill at Stage 1. By virtue of Rule 12.2.3a, Liam MacArthur MSP may well attend the meeting as the member in charge of the bill. As part of our scrutiny of the Assisted Dying for Terminally Ill Adults Scotland Bill, the committee undertook informal engagement with the Scottish Assembly last week to hear from adults with learning disability and autism about their views in the bill. And I'd like to place on record the committee's gratitude to those who participated in that engagement for sharing their views and experiences with the committee. And I'll now ask members to provide some feedback about what they heard and learnt as part of that session. So can I start with yourself, Emma?
Yes, I wasn't sure that I was doing theme 1.
It's about the Scottish Assembly and feedback from the Scottish Assembly.
Of course, thank you very much. Yes, I just wanted to put on record that everyone who came had obviously made a great effort and were very thorough in how they were prepared. We know that the PAC team did a fantastic job in organising it. And just setting up the room, and the people that I engaged with and heard from were very well prepared, very well informed, and I just wanted to say a big, huge thank you to them.
Brian Whittle?
I think that one of the things, the lessons that I learned from last week was never preempt or prejudge what you're about to hear, because I don't know what the expectation was from that meeting, but it certainly far exceeded anything I thought I would get from that meeting. Incredibly well prepared, incredibly well informed, and not shying coming forward. And what they said was not what I expected. So I think I'd just like to put on record my thanks to them, as I said, and the lesson learned is don't preempt what you think you're going to hear.
Paul?
Thank you, Convener. I would echo the sentiments expressed by colleagues in the session last week. I thought it was very effective, and I certainly learned a lot from it, and I'm sure colleagues did as well. Some perspectives that are brought forward that I hadn't previously considered were, for example, transitions to adulthood and the impact on young people having a very supportive structure around them, then transition to adulthood, maybe having that facility and that support removed. That may influence people's outlook on life. Similarly, the issues around self-administration for people with significant disabilities as well. And, there were a number of interactions there which I thought were really helpful in terms of understanding the practical application of the legislation as currently drafted. So, appreciate that.
Okay. Thank you. I should also note that an anonymised note of the discussions that took place as part of the informal engagement will be included in the committee's Stage 1 report. And we'll begin today's scrutiny of the bill by taking evidence from organisations that represent individuals with long-term conditions. Vicky Cahill, Policy and Public Affairs Lead, Alzheimer's Scotland. Stephanie Fraser, Chief Executive, Cerebral Palsy Scotland. And Susan Webster, Head of Policy and Campaigns, MND Scotland. And I welcome you all to the committee. And we'll move straight to questions. And Carol Mochen.
There. The first theme I think I've been asked to explore is to raise the definition of terminal illness. And there have been a range of views expressed about the eligibility criteria used in the bill around the definition of terminal illness. And I wondered whether each you might just express your view on that. And in particular, whether you think conditions such as MND, Alzheimer's, cerebral palsy should or would be covered by that definition. MD in particular first.
Go first. Yeah. Thank you for your question. And I am here from Cerebral Palsy Scotland. And what I would say about cerebral palsy is that it is an umbrella condition. It is classed as a non-progressive neurological condition. But in terms of whether it fits the definition of this bill, you're not going to get any better from it. So it is lifelong. And actually, but it is not a static condition. So how you are affected by your cerebral palsy is very much affected by how profoundly affected your body is from the condition, but also what access you have to care and support and ongoing treatment throughout your life. So if you don't have that access to care and support, then then it is likely that your life could be shortened as a result. And I suppose what the concerns of our community are about the word terminal, we see people who, when they're accessing healthcare, are sort of, things are put down to their condition. So, that's because of your CP, or that's, we can't do anything about that because, and then their life expectancy will worsen because of that lack of access to treatment, rather than necessarily the lack of access to the fact that cerebral palsy will kill you in the end. But I think our concern is that the definition of terminal as in this bill could apply to many long-term conditions, and that actually, how clinicians ascertain how long someone has to live, I would suggest is a best educated guess.
So you don't think it'd be helpful to have any time, expected time frame for people in terms of their terminal illness diagnosis?
No, because I think it's a best guess.
Okay.
Yeah.
Thank you very much. I don't know, Susan Webster.
Hi, thank you. Well, we would be very keen for the definition to stay as it is in the Social Security legislation. That was a kind of hard fought for inclusion in that legislation by ourselves and a number of other charities. I think it would be really unfortunate if there was a different definition in this bill. You don't want different definitions of terminal illness in different legislation, ideally, and we are content with the definition in the Social Security legislation. And just for note, although we are part of the kind of long-term conditions group, MND is definitely not a long-term condition. So, I mean, average life expectancy with MND is just 18 months after diagnosis. So it's a little bit different from that point of view. But yeah, just to go back to your original question, yeah, people with if the Social Security legislation is included in this bill, then people with MND would be covered with that definition of terminal illness.
Okay, thank you very much.
So Alzheimer's Scotland believes that people with dementia would fit within the current definition as it stands. However, what we would be seeking to do is to ensure that the scope and the parameters around the eligibility criteria are clearer and much more specific. At the moment, we believe that they could potentially be subject to misinterpretation, and that could be to the detriment of people who are seeking to access this type of legislation. The current definition doesn't set out clearly the circumstances under which people living with progressive terminal conditions like dementia would potentially be able to access and when they would be able to access this type of legislation. So the example that I would give is that dementia itself is a continuum. It continues, it progresses, it changes. People's needs and symptoms continue to vary over a period of time. The SIGN guideline for dementia identifies that there are 4 main stages of dementia. So that's namely early, moderate, severe and advanced. And clearly from the definition as it's set out in the bill at the moment, those with advanced dementia would fit within the intention to include those individuals in that definition of what a terminal illness is in terms of how far advanced it is and how progressive it is. However, looking at the symptoms that arise within severe dementia, those could also be included within that. So the use of the words like advanced or progressive, they need to be much more specific about what those means, and what is included has to be much, much more descriptive to ensure that those that would be eligible to access this type of provision within the legislation would be able to do so fairly and equitably. And the definition at the moment, in our view, is much too wide and not specific or clear enough to make sure that we're not missing out those individuals who might be able to or shouldn't be able to access those provisions.
Okay, that's helpful. I don't have further questions.
Sandish Kahani's got a supplementary.
Thank you, Convener. Declaration of Interest of Practising NHS GP. Stephanie, thank you for coming today. Given your answer about the definition, do you think we should scrap and change the social security definition then?
I mean, the social security definition was put in place for, as Susan said, very hard-fought reasons. And I think as far as I'm concerned, looking at people with cerebral palsy, I don't have an issue with the definition in the Social Security because it was put in to access very particular benefits for people with conditions that there is a timeline. What I'm saying with cerebral palsy, there isn't it's a lifelong condition. So no, I'm not suggesting I have any issue at all with the social security definition, because that's about accessing benefits. I think when we're assessing when is somebody going to when is their life going to come to an end, I think that's what I am concerned about, because people with cerebral palsy struggle to access health and care needs, particularly at the end of life. They struggle to access palliative care. They struggle to understand people. They struggle to get services from people who understand the impact of their condition on their life. So that's why in this context I am saying I'm agreeing with Vicky actually that it's not descriptive enough and it's vague, whereas I think it's a separate issue when you're accessing benefits.
Okay. When it comes to best guess, obviously no one can be absolutely certain of the exact time of death, but in a lot of cases I think we can assume some form of timeline, and that's how one accesses the DS 1500, which unlocks a lot of money to allow people to live and have benefits that they otherwise wouldn't have in their last moments. And that is, again, as you describe, a best guess. So should we be getting rid of that because you describe it as a guess?
But we're talking about two different things here. We're not talking about access to care. We're talking about when we think we're talking about access to when somebody should be able to die. And I think just in the context of cerebral palsy, that is complicated, because access to care is something that they will probably have had throughout a lifelong moment. And what we're trying to assess is when's that moment that might change. And considering there are no specialists for cerebral palsy within adult services in the NHS. There are neurologists, but I know from my work on the National Advisory Committee for Neurological Conditions that most neurologists don't see adult patients with cerebral palsy because it's not classed as a progressive condition. There aren't drugs that are routinely, keeping the condition in either keeping people well, and people really struggle to access healthcare services. And I'm just pointing out that therefore when other things happen, they might not be addressed or they might not be recognised as part of their condition, or people might feel that there is no hope because they have no access to support and care. So this is not in comparison with accessing benefits. This is about how we care for people throughout their lives and ensure they have a good death.
Thank you.
Thank you. Emma, I'll just put on record that I hold a bank nurse contract with Greater Glasgow and Clyde before I start asking my questions. So I want to look at the area of human rights. And in the context of human rights, do you think the bill contains sufficient protections in relation to vulnerable groups? And I suppose in particular in the groups that you represent. And if you have any concerns, what could be done to address these? Vicky, did you want to start?
Thank you very much, Convener. So we recognise that the balance of rights is very complex and challenging when considering provisions for assisted dying. Finding the balance between the right to life and those around autonomy, self-determination, equality and dignity. It's a very fine path to tread, and it is very challenging. I think the decision to either include or exclude people with dementia from accessing these provisions will have significant implications on their human rights, regardless of which decision is made in terms of the direction of travel as to whether or not people with dementia are included within these provisions. So, for example, by excluding people with dementia from accessing provisions for an assisted death could potentially be seen as an erosion of their rights. However, we also see that there has to be a balance between protecting those particular human rights and finding that balance in terms of protection and safeguarding, because people with dementia are in a particularly vulnerable group, and we need to make sure that there is no harm that is to be done. I think one of the areas that's not particularly well addressed within the legislation itself are the provisions around looking at advanced care planning and advanced directives, and how decision making around that is considered and addressed entirely. So, for example, people who draft legitimate legal advanced directives at a time when they do have capacity, because capacity is a particularly pertinent issue for people living with dementia. If they make those directions at a time when they do hold capacity and their capacity then changes, there's not much that's been said in terms of what happens to those individuals who have made a clear request that at a particular point in life or a particular point in their experience of dementia, what then happens in terms of being able to enact that if there are changes to their capacity. And I think
move on to that. Some of my colleagues have got questions more about capacity. So I suppose I'm trying to focus more on human rights.
Human rights, yeah, and absolutely, it's finding that balance. But by not ensuring that we address those wider issues around those particular areas, then there is that risk of eroding human rights, and we have to make sure that we consider all of the bill and all of the contexts as a wider piece. We can't see this all in isolation, and it has to be seen against a much wider framework, again looking at health and social care and those aspects to make sure that people's human rights are being recognised, respected and upheld.
Thank you.
I mean, I think we have the same concerns that, that there are problems about people who might be included and there are problems about people who might be excluded. We have particular concerns around communication and people being able to communicate with, with anybody as regards this. So, we know of people who are non-verbal and who, end up, for example, in hospital without their communication device and things. And those are terrible cases and shouldn't happen, but they do, and that worries us. I think the other thing we have also seen with our population, which actually Cerebral Palsy Scotland is trying to address, is supporting people to have the language and have be able to have difficult conversations and challenging conversations, and to be able to advocate for themselves when they are non-verbal. And this is a challenge we see, throughout everything. And in a situation as regards this, it would be even more stressful and challenging. And things like, considering is the pre-programmed language settings on a device up to the ability to have these difficult conversations are things that we think would need to be considered. But I agree. I do agree that there's a problem about who is included, and therefore when you look at the human rights issues about therefore who isn't included.
Susan? Broadcasting will operate the microphones. You don't need to switch on.
Most of our concerns around human rights really relate to the self-administration aspect of the bill. So whether you would prefer me just to address those later in the meeting, I can do either.
I suppose in terms of what you mentioned there about human rights and that specific issue, it was certainly something that was raised with us in private session with members from the Scottish Assembly, was about that self-administration, and for those who did have capacity but perhaps were physically unable to do that. So I suppose I'm certainly keen to hear what MND Scotland's views are on that part.
Absolutely. I mean, if self-administration only is included in the bill, it will inevitably exclude many people with MND because of their inability to use their hands at certain stages of the illness or their ability to swallow. So actually the self-administration part of the bill would really limit their ability to choose assisted dying if that is what they want to do. And what it might actually, because MND is a rapidly progressing illness, what it might mean is that they choose, if they do want to take up the opportunity for assisted dying, they might choose to do that earlier in their illness than they would ideally do so, just so that they can actually physically administer the medicine. So in terms of a sort of human rights aspect, I would say that that would be, you know, something to consider in relation to that.
Stephanie, you wanted to come back in?
If I can just come back on something on self-administration. I think it's not clear in the text what that actually means. When we were talking outside, you know, I think you'd assumed that it was sort of orally and somebody would have to physically take a pill. But, you know, it is possible self-administration could be, you know, if you can operate a head switch or something. So what does self-administration mean? What does it mean for people that are peg-fed, for example? And actually it's not clear that the way that this would happen is being left to secondary legislation. And I think actually there are some things about the way it might happen that we would like to see explored through, you know, at this stage rather than left to something that might be directed later.
Thank you. I think we're going to go on and explore quite a lot of the themes that we touched on there through other members' questions. And I'll move to David Torrance.
Thank you, Convener. Good morning, everyone. What do witnesses think of an approach to capacity taken by the bill?
Thank you very much. Seems pertinent that I respond, given that those living with dementia have their capacity brought into question quite often. So let me firstly say that people often assume that people living with dementia lack capacity, but that those living with dementia actually retain the same legal capacity as any other citizen within Scotland. In order to determine whether or not someone then goes on to lack capacity or to lose capacity, the Adults with Incapacity Act clearly sets out that that should be done on a case-by-case basis and on a decision-by-decision basis. And any test of capacity shouldn't be seen as a blanket approach or a general test of capacity. Unfortunately, our experience is that people are often determined as either having capacity or not having capacity. And I think we need to be really clear about the fact that capacity should be determined on a decision-by-decision basis and not, you know, a one-size-fits-all approach. In terms of the definition of capacity as it's described within the bill at the current time, we feel that the definition again lacks a bit of clarity and specificity in terms of what is and what is not included. The definition as it's used is the one taken from the Mental Health Care and Treatment Act of 2003. And in fact, that piece of legislation only applies to a very small number of people living with dementia in practice. So we think that actually the bill itself could be improved by taking the opportunity to really clearly define in its own terms and with its own scope and within its own parameters exactly what it means by that term of capacity, to make sure that it is clear and that it is quite explicit. In terms of doing that, it would enable us to really understand clearly, and that includes those who might choose to access the provisions, but also support those who are going to potentially deliver those provisions, you know, who can and under what circumstances people might be able to make use of the provisions set out within assisted dying. And then it would remove that ambiguity and the potential for misinterpretation or misunderstanding. So I think there's real scope there for, you know, the bill to be improved in terms of providing those extra parameters and being more specific within the context that it finds itself in.
Yes, we're concerned about how vague it is about capacity. The current text is about capacity. So 1 in 2 people with cerebral palsy have a learning or intellectual disability. And as Vicky said, that doesn't necessarily mean they don't have capacity. And I suppose our other concern about the text as it stands is who and how is this being assessed? So, I've been in a number of conversations where people have said, oh, well, people are, GPs, for example, are perfectly capable of assessing capacity. And absolutely that may be the case if they know the person who they are assessing. In the financial memorandum, it talks about people having to be trained and going on online courses to be trained in assessing capacity. And I would very much hope that there was more thought given to how capacity was assessed than just a few online sessions.
We don't actually have any comments in relation to capacity for people with MND. Thank you.
Just to add as well, with reference to the test for capacity, Alzheimer's Scotland raised quite a significant omission in terms of how capacity would be tested, and believe that this is something that really needs to be addressed within the legislation, and that is in relation to being able to act on a decision. So at the moment, the test for capacity is based on previous legislation that sets out how someone's capacity should be tested and the things that they are able to do. And the one part that seems to be missing from that is the ability to act on a decision. So given that self-administration forms part of the legislation and how the legislation would move forward, it would seem appropriate that being able to act on a particular decision is an important part, and that really needs to be addressed within the legislation itself.
To what extent is the Bill's approach to capacity compliant with the recommendations of the Scott Review? And if not, how could it be made compliant with the Scott Review?
So the Scott Review is obviously, we're currently undertaking a huge review of how we look at different areas of mental health legislation. So mental health legislation undertakes a huge number of different pieces of legislation. We've currently just consulted on the Adults with Incapacity Act, and that includes issues around testing capacity. As I've just pointed out, that failure to have reference to the ability to act on a decision is really important. So it's not just about understanding the information, retaining the information, being able to communicate it back. You actually have to be able to act on it in order to carry through, right the way through to self-administration of medication within this particular bill. So that's probably where we would have as our starting point for improving the legislation to make sure that it does become compliant. And again, bearing in mind the Scott Review recommendations are going to be carried out over a period of time, it's important that we make sure that as we move through those recommendations and as we make changes to legislation to satisfy those recommendations, that we continue to make sure that if this bill moves into through the legislative process, that it is also compliant as well.
Thank you. Thank you, Convener. Good morning to the panel. Just sort of supplementary there to David Torrance's questions there. I was listening to what was being said there, and I just wanted to clarify that in terms of testing for capacity, do you think it's an issue here around the potential, no matter how well trained we have a medical staff whose job it is to determine capacity, could come to a different conclusion than the person's consistent GP who's seen them over a period of time and understands a condition, specific condition to that individual? Is there a concern here that there could be two different kind of conclusions to capacity?
Example to illustrate that. So, somebody with cerebral palsy who might have been to mainstream school and who physically isn't terribly involved, maybe and I'm thinking of people we know, maybe assessed, for example, to be able to live independently at home. But what hasn't been picked up are sensory processing issues. So, for example, somebody physically might be able to live independently on their own, but in order to make a cup of tea, they need someone to remind them to put water in the kettle, to plug the kettle in, to put the kettle on, to get the cup out, put the tea bag in, etc., etc., etc. And it's really subtle. Capacity is a subtle thing, and I think I think of those people who may present one way, but if you know how they live or what support they need to live, that somebody else may slightly assess it differently. Now, I know that making a cup of tea is a very different thing to what we're discussing here, but I can just, that's the only example I can, that's the kind of example I can give you that. Nobody wants to underestimate the abilities of people. We want to support them to make their own decisions and to live as independently as possible. But sometimes there is a sort of, actually what their real issues are is potentially sometimes overlooked.
I think, if we take that slightly further than that, I think it's what I'm getting at is that a regular healthcare professional who knows the person will notice subtle changes, and
what concerns me for people with CP is that they do not have a regular medical person, potentially their GP, but the days when we all know our GPs and see them regularly aren't necessarily the days we live in at the moment.
Thank you.
Thank you. Vicky, can I explore a little bit more about advanced directives? I'm going to be honest, I'm very nervous about the idea of an advanced directive when it comes to this bill. I don't think it should, if somebody has lost their capacity, I don't think that the advanced directive should count in this particular instance, and that's my opinion at the moment. But I would like to know what yours is and see what you believe should happen with an advanced directive in the scenario of somebody who has perfect capacity when they create their advanced directive, but then clearly, not in a subtle case, clearly have no capacity when it comes to the time of potentially using it.
So we have adopted a very neutral approach to this bill in terms of we choose to neither support nor oppose the provisions of the bill, merely raise those concerns and considerations that we believe have to be addressed to ensure that if the bill does follow through the legislative process and becomes enacted, that it's complete, full and robust and covers absolutely everything. There are some real challenges around advanced directives, as you rightly point out. So someone at the time when they are doing it will have capacity. It's one of the requirements and provisions for setting out an advanced directive that you have capacity at that time. We believe that we have to consider what happens as that goes forwards and looking at both sides of those, of that particular coin, then there's a potential in both directions to really affect the human rights of an individual. So someone who has very clearly set out their requests or their personal wishes in terms of what happens as their condition progresses. Who is to say that it is not right that, if they have clearly expressed a wish that shouldn't be followed through? However, the flip side of that is that obviously, how is it possible then to test whether or not someone has changed their mind or had a change of opinion that hasn't been tested since the point at which the advanced directive was completed? So, for example, if someone is going to create an advanced directive, they may do so or are more likely to do so early in their diagnosis and may have a preconceived idea of what it is to live with a condition like dementia. Their experience then may be different, particularly if we have access to high quality health and social care that provides the kind of care and support that enables people to live well with dementia. And we would suggest that it is possible to live well with dementia, with the right kind of care and support. But again, without that, we have to look at it. So unfortunately, I can't really give you a scenario under which we believe that we should move forward, but believe that these are issues that we have to explore much more deeply, and we have to engage people around what their particular views are to make sure that, you know, any decision making that's made around advanced directives and advanced care planning are done so that they are done with integrity and that they manage to uphold rights but provide the right level of support and protection.
Thank you. I mean, I think we're trying to scrutinise the bill to try to find the right thing to do when it comes to advanced directives, and that's why I'm asking to see what the opinions of experts are. Can I just move on to when you were talking about the definition of capacity? Could you point to somewhere that has a better definition, in your opinion?
So capacity is really complex, and there's lots of different examples in terms of how capacity is considered and looked at. In terms of alternatives to the ones that are there, I think that the basis that we have at the current time is helpful and useful in terms of the ones that come from pre-existing legislation. However, as we're going through the Scott Review and looking at those recommendations, that was a thorough review conducted across a whole range, and we need to look at the examples and the tools and structures that have been recommended by the Scott Review to look at capacity and look at it in depth. And more broadly as well. So I think looking firstly to the Scott Review for their recommendations would be a good starting point.
I was just wondering if anybody else had an opinion when it comes to advanced directives. Thank you.
Can I just probe a little bit more on that topic of advanced directives? So I keep what you're saying about advanced directives with regards to if this bill became law. Would you recognise advanced directives that someone might put in place which are about, you know, not consenting to treatment or not being put on life support or not being resuscitated, regardless of whether they then had capacity at the time that that intervention may or may not take place?
So a lot of that comes down to individual subjective decision making that goes on around an individual's care and treatment. Sometimes decision making can be done in conjunction with family members where an individual's not able to share or express their views, particularly if, for example, there is a power of attorney or a guardianship order in place. Some decisions are made at a medical level, and so a lot of that decision making is done there. So again, not within the scope of this particular discussion, but again, something that could be looked at much more widely and much more broadly in terms of how advanced directives are managed, because what we are finding within the care and support that people with dementia are looking to access is we're encouraging people to look ahead to the future. We encourage people to plan ahead and to try to make the most of the opportunities that they have to think about what it is that they would like and you know, how they want to be treated, cared and supported going forward in the future. So societally, we actually have to think much more widely about how we support individuals to do that. And I appreciate that's not necessarily within the scope of today's discussion, but certainly we could move that forward.
Can I just add to that, that thinking of adults with cerebral palsy, it's back to my point about difficulties of communication. We have too many examples of adults who have have full capacity but cannot communicate and don't have the right language on devices or wherever to challenge and to have conversations. So decisions are often made about their care and support that they're not happy with, but they find it very difficult to challenge. So I just wanted to add that in at this point.
And just to take that a step further, and I'm going to come to Brian Whittle because I know he's got a supplementary on this too. So one of the issues that was raised with the committee last week was about guardianship and about whether guardians who have legal rights to accept or refuse medical interventions on behalf of their guardian, whether or not guardians should have a right to have a say were this bill to be enacted. And I'm just wondering if, I suppose it's a step on from advanced directives, if you would have any thoughts on that.
I'm not going to respond specifically on guardianship, but what I am going to say that what we see with sometimes, not all the time, but we sometimes see a difference between the person with cerebral palsy and then nearest and dearest about what is agreed is best. So it's a really, really complex area. And I come back to my point that I think if we can support the person to be able to communicate and have difficult conversations and have the right vocabulary, etc., then that would be an improvement.
Thank you. Brian Whittle.
Thank you. So I just wanted to clarify a point here in terms of talking about advanced directives. Am I correct in when I'm hearing you say that the problem with advanced directives is that you then, if they get to a certain point in terms of capacity, it's very difficult to understand whether in that journey they may have changed their mind, and therefore that in itself is an inherent issue with an advanced directive. Is that am I?
So there is the scope for that. So if someone's so speaking about someone living with dementia, and as their condition progresses, they may have made an advanced directive early in their experience of the condition. As their capacity changes and moves on and becomes much more diminished, it may be more difficult to ascertain whether or not someone has had a change of mind or whether they are still of the opinion that they would choose to have an assisted death. So in both directions of travel there, it's difficult to do that, be able to test that or to look at that if an individual is unable to express themselves or have the sufficient capacity to be able to do so. So again, with the advanced directive then, it's about what measures would be put in place or what limitations might be put in place around advanced directives in terms of being able to access a provision such as assisted death.
Thank you.
Mackay.
Thanks, Convener. We've covered fluctuating capacity a little bit already across the meeting so far, but I wanted to come back to those things that we might need in the bill to adequately address that fluctuation in capacity. What provisions should be added so that we don't see individuals like those with Alzheimer's feel like they're being forced to pursue assisted dying prematurely because that is when they can demonstrate capacity? I can come to Vicky if that's okay.
Thank you. So determining capacity is a real challenge for people with Alzheimer's or any other form of dementia, because capacity can change and move. It's not static, it doesn't stay the same, and it can change from day to day. So from day one, an individual may struggle to show and to satisfy a test for capacity, but on a different day they may be able to do so. So it's about finding flexibility within the legislation to allow for those with fluctuating conditions to be able to find the opportunities to really be able to express themselves. It's really important that those who do have capacity are supported and enabled to be able to express their view and opinion when their capacity is in place. In terms of looking at how capacity is actually tested, again, this is where we need to look at those flexible options. So lots of things can determine whether or not an individual manages to satisfy or not a test of capacity. So that could be depending on the environment, the time of day, the actual day of the week. So again, it's about finding those opportunities where individuals are supported to do that, and we have to have the flexibility and the options built in to how we address testing capacity, because it's really difficult to do that. And even, you know, there are examples where an individual may be determined as lacking in capacity or may be determined as having capacity, and where that's inappropriate or it's wrongly done, then there's real potential for harm to an individual, either because they haven't been able to express their views or because they have been able to, you know, be involved in decision making where perhaps capacity is not at its strongest.
Did you want to come and say?
Well, if I understand it, your question was about fluctuating conditions. So cerebral palsy is not a fluctuating, it's not a progressive condition. But as I said before, it's not static, and therefore how someone presents, can very much depend on what care and treatment they have or haven't had access to. And I think one of my issues with the legislation as it stands at the moment is that neither the registered medical practitioner nor the independent medical practitioner needs to have any specialist knowledge of the condition with which the person is saying that they are going to die from. And I think that is an error. And I think, they may ask for specialist input, but I would suggest that it might be stronger if they must ask for specialist input on that particular condition. And that, I think, there are so many conditions, particularly in the neurological sphere, that are fluctuating. And, if specialist knowledge isn't part of the assessment process, then I think that's a glaring omission.
That leads me nicely on to my second question is there places in specialist services at the moment where actually decisions that need to be made about people's care do take into consideration that fluctuating capacity, where we can actually draw on good practice that's already happening, or is this something that actually needs improved across the board?
I would suggest that we need some improvement across the board. Dementia specialist services are few and far between in terms of the quality of care and the access to care and support for individuals. It's very much that postcode lottery. There are small pockets of good practice that do exist, and where they work incredibly well. However, it's not the experience of everyone. So we need to look at a much broader, wider approach to improving access to care and support.
I completely agree. I think it is concerning that there's a lack of access to specialist adult support for people with cerebral palsy, and services in Scotland fall far short of the NICE standards and guidelines for adults with CP. We don't have signed guidelines, but we do adhere to the NICE guidelines, and we fall short. Just simply in terms of reviews and access to specialist care. I think the other thing also is that particularly for people with neurological conditions, access to palliative care service is too little and too late. And therefore, I would advocate I would advocate strengthening palliative care services hugely, and access to palliative care for people with long-term conditions.
That's great. Thank you. Thanks, Convener.
I believe Emma Harper has a supplementary on this, and then if you can continue on to the next thing.
Righty, thanks, Convener. Just thinking about the eligibility and long-term conditions, and thinking about Parkinson's. I'm a registered nurse, I just remind everybody about that. But under the eligibility on Section 3, it says that a person has capacity to request lawfully provided assistance if they are not suffering from a mental disorder, which might affect the making of the request. And because of issues around depression, it's considered a mental disorder. But is it? How severe is it? people that might have MND diagnosis might also have a pre-existing depression diagnosis, or somebody with Parkinson's, it's a long-term condition, is that a mental disorder? So do we really need to assess what level of understanding and knowledge there is in the persons who will be making the decisions to determine capacity? Does this need to be fleshed out a bit further?
I think you've hit a number of nails on the head with this, and this absolutely backs up my point about the need for input for specialist knowledge of a condition. And your example of Parkinson's and depression is an absolutely spot on one. I think the other thing is that we know with our population and generally, with people with neurological conditions in general, that access to care and support and ongoing treatment can absolutely colour a person's experience or their view of what the future might look like. And I think there is in section 7, for example, the registered medical practitioner may discuss any palliative or other care available, but insofar as the registered medical practitioner considers appropriate, and I think that is that a real option? Are we giving people a real option if that palliative or other care available isn't available? So,
okay, thanks. I will move on to my the next. I'm going to cover coercion. So I'd be interested to hear what you think about health professionals, whether they have the appropriate skills to be able to assess whether coercion has taken place on an individual who is seeking assisted dying support.
I think this is where my concern about the registered medical practitioner not necessarily having to have known the person. So I think in the discussion previously, we've assumed that it might be a GP, and we've assumed that the GP may or may not know the person and the person's family that they are assessing. And I think there is an omission here about how long must somebody who is assessing the family circumstances have known the person and their family circumstances for, and who can provide evidence. So I'll give you another example that an adult with cerebral palsy whose social worker actually wanted to change their care package, and because there are no clinical nurse specialists for CP or whatever, actually Cerebral Palsy Scotland was the organisation that had seen this individual more, clinically for longer than anyone else, and we were asked to provide supporting evidence, and it was not accepted because we were not part of the NHS, even though we were the organisation that knew this person better than anybody else, because of their care circumstances. So I think, I give that as an example of who should be able to feed in, who must feed in, and in what capacity should. Capacity is probably not the right word to use in this circumstance, but how should people know the individual and their family circumstances, and who are the right people to bring forward any appropriate evidence?
I suppose for Vicky and Susan as well, it's like vulnerable people who have Alzheimer's, dementia, MND. Do you feel as if there is a risk then of coercion, and then how do we safeguard against that?
I think it's really important to understand that whilst a specialist may have the knowledge and skills and understanding required in order to test someone's capacity doesn't mean that they automatically have the knowledge and skills to be able to assess the presence or the absence of coercion around decision making. So I think in that respect it's really important that, you know, we look at who is doing that test of, you know, coercion and to make sure that it's there, because we recognise that people living with dementia do fall into a particularly vulnerable group and are at risk of abuse and are at risk of harm in that respect. One of the other issues that we would also look at in terms of coercion is thinking not just about it in terms of undue influence from an individual within a specific set of circumstances, but looking at it much more widely in terms of undue pressures that might come from elsewhere that might influence an individual's decision to seek an assisted death. So that perception, for example, of being a burden, the perception of, you know, being stigmatised or discriminated against within their day-to-day living, their experiences of you know, health and social care, or, you know, social interactions that they feel do or do not make their life worth living. So I think coercion needs to have a much wider approach in terms of it being coercion and undue influence overall.
We don't have an organisational view on coercion.
About overt coercion versus the subtle coercion you're talking about, Vicky, about being a burden. We hear that in just conversations and emails that are coming into my inbox about how do we protect people, and they feel that. Do you have, I suppose, concerns about wider definition of what is coercion, what is pressure, what is protecting someone from feeling like they're vulnerable and a burden?
Absolutely. We think that, you know, in terms of looking at it, then obviously those overt attempts to coerce someone into making a decision which would go against their wishes or their personal preferences are perhaps easier to identify and to look at. But in terms of that broader test, it's about understanding about you know, what those other influences are and whether or not they can be addressed. And I suppose these are much bigger asks in terms of looking at ways to remedy and to address them. It's about looking at services and supports. It's about looking at, you know, how we address issues like stigma and preconceived ideas about what it is to either live with a particular condition or to care for someone with a particular condition. And particularly around dementia, there are plenty of preconceived ideas of what it is to live with a condition like dementia. There's a lot of fear, there's a lot of worry, and again, it's about, you know, looking at much broader how we support individuals through those processes so that they can live well with their condition. So I think we do need to broaden out that scope of what coercion is and where those influences come from and where that decision making comes from. One of the particular issues specifically around dementia would be around the cost of care. So most people living with dementia, as their condition progresses, will find themselves not receiving health care, but actually having to delve into social care where they're expected to pay for their care, particularly as their condition progresses and they find themselves being forced into care home or residential care options because there are no other alternatives. So we have to then look at that much bigger picture of, you know, doing that, because we don't want the cost of care to be an influence on decision making about whether or not you choose to continue to live or to seek an assisted death.
Okay, thank you. Thanks, Convener.
Brian Whittle.
Thank you, Convener. I mean, the issue of palliative care has been raised several times. And I suppose the question is around concerns have been raised, and I wonder if these are things we can explore around the level of palliative care available and the influence then on potentially, you know, seeking a remedy of assisted dying because inability to access palliative care. I wonder, Susan, if you have a view on that.
Like the others on the panel, I would highlight that we are a neutral organisation. So in terms of whether assisted dying should be lawful or not, we believe that there is room for much improvement in palliative care and social care, regardless of whether or not assisted dying is available to people by law. There's, we responded quite recently to the palliative care strategy, for example, and we ran a focus group for that. We highlighted issues, the people that took part who had lived experience of MND, highlighted equitable access across the country in relation to palliative care, improved funding, the need for holistic palliative care, whether that be physical, psychological, but also in terms of working with social care and to include all members of the family as well, not just the ill person, and really to be available from the point of diagnosis rather than it being, as it's commonly perceived, a kind of end-of-life option available. With social care, I could talk forever about how I think social care could be improved, but really for social care I think there needs to be terminal illness as a group needs to be much better recognised in discussions about the National Care Service, and terminal illness as a group of people within discussions about the National Care Service is largely omitted, and I think that is something that needs to be addressed, particularly when we're discussing what we're discussing today. But as I say, I think these should be in place, that there needs to be huge improvements in both of these areas, regardless of whether or not assisted dying is introduced.
If anybody else has got any comment on...
I mean, I just have a figure here that around 18% of children, and children in this case would be under 18, so this just has an effect if this bill is for age 16 and above. But around 18% of children with CP die in childhood, and only a quarter are able to access specialist palliative care. And I would agree with Susan that, Cerebral Palsy Scotland believe that everyone has the right to supportive care throughout their life and to quality end-of-life care when it is needed. And that is not currently available to enough of our population.
Do you think that that has the potential to influence somebody's decision to access assisted dying?
Yes, particularly when you factor in other factors that Vicky mentioned, about lack of independent living accommodation, lack of choices about, what they, how their care is provided or where they live or what they can do, even, we see people, who struggle to, leave the home because mobility needs aren't being cared for, being provided. So there are a whole load of issues that can lead to a feeling of, things aren't worth it.
Anything to add, Vicky?
Yeah, so again, just kind of in agreement with Susan and Stephanie, to say, assisted dying has to be seen in that wider context of long-term palliative and end-of-life care. It doesn't stand alone. It has to be seen as part of that much wider provision. We would support the responsibility of the health and social care system to make sure that everyone's physical, psychological, emotional, practical, spiritual needs are met. And again, palliative care provision, long-term care provision, end-of-life care provision for people living with dementia is very limited. Again, there are positive examples in areas, but it's not universal, it's not readily available, and we need to make sure that there's high quality provision for everyone, regardless of their background, regardless of their circumstances. Shouldn't be limited because of where they live or how much it costs. And again, it comes down to that lack of choice. At the moment, it's very much a case of, you may have one option and choose to take that option or to not take it. But actually, what's available at the moment isn't necessarily meeting both the needs and the wishes and preferences of individuals. So there's a huge amount of more work that can be done in terms of improving what's on offer, and failure to do that would potentially, have an impact on someone's decision making and whether or not they would choose to access the provisions within this bill or not. So I think it's important we cover that.
If I could just I'll bring you in, just want to add another layer onto that, if I may, to see if I can make it more complicated. I suppose then, if the consensus is that the access to palliative care is at best patchy in across conditions and across different areas, how do we then? Where's the line in terms of, we've reached a level of palliative care that satisfies our concerns around, this being an influence on a decision to access assisted dying? And that is the possible question, I suppose, but I suppose it's one I want to put out there.
I think we've all responded to the consultation on the palliative care bill, which is currently before you. So, I'd refer you there to the beginning. But I think it is interesting that there isn't a statutory right to palliative care in Scotland, which there is now in England. And I think, that would be something that we would want to see changed. I think the other interesting thing, and I just sort of raise this because I don't know where else to raise it, but, much of palliative care is, particularly if you think of the hospices, is provided by the third sector, which, as all of you will probably know, are, under huge constraints at the moment. And I think that's interesting that there is, so much of palliative care is provided by the third sector. And with this bill, the only place it actually mentions that assisted dying will be provided by the NHS is in the financial memorandum bit. I've read it assuming that we are assuming that if this bill comes into force, it will be provided by the NHS. But there is a question of, should it be provided by the NHS, or should there be, on a par with the palliative care system? I mean, I'm not suggesting this is that this is a should or shouldn't, but I'm just saying it's not. In the English bill, it very clearly says that the NHS must provide this service. This bill doesn't, which I think is interesting when we look at palliative care, where so much of it is provided out with the NHS and through third sector organisations. So I just leave that with you as a, how should it be done?
If anybody else has got anything to add.
So, moving on a little bit, but still touching on some of the issues that you've spoken about already, and I'm interested to seek some of your opinions on assisted dying as a treatment option. So, is the bill clear enough on whether doctors would be expected to offer assisted dying as a reasonable treatment option? We're aware, as a committee, from evidence that we've taken from overseas colleagues, that in some jurisdictions it's prohibited for that to be for it to be raised by a clinician, that it has to be patient-initiated conversation, whereas in other areas it's not. So I'd be keen to hear if you've got any views on that.
I mean, I note that here it's not, and again, back to the comparison with the English bill, that they can raise it. I think the only thing we would say at Cerebral Palsy Scotland that concerns us is that, the reality for many people with cerebral palsy is that they cannot dress themselves, they cannot move without assistance, they cannot often speak without assistance, or feed without assistance, or toilet without assistance, or whatever. That does not mean, and we get this time and time again, that they are suffering. And I use that word specifically, and I note that is not in the bill, it's not about people suffering. But one of the things that comes back again and again for people with CP is that their quality of life and the value of their life should be no different to anybody else just because they can't do all these things. And I think, yeah.
Back to what I was asking specifically about, which is about whether doctors should be expected to offer assisted dying as a reasonable treatment option.
Well, we would suggest not.
Anyone else on the panel have an opinion?
We don't have a view on that. I think that would be other witnesses would be better placed probably to give a view on that.
Okay.
I'm thinking about health profession.
Likewise, we would maintain a kind of neutral position in terms of, you know, whether to favour that or not. We would remain quite neutral, and again, there are others who are better placed than we would be.
So it's on the flip side of that coin then. You know, should the bill expressly prohibit doctors or other healthcare professionals from raising assisted dying as an option? And would this provide some reassurance that people with long-term conditions, such as those that access services with your organisations, would not face pressure to have an assisted dying when seeking other forms of support?
I think I come back to the point that people with CP struggle to access care and support, and we are concerned about the change in the doctor-patient relationship. You know, if this is proactively suggested.
Okay, that's helpful. Vicky or Susan, would you want to add anything to that? Okay, thank you. Joe Fitzpatrick.
Thank you. I was going to ask some questions about conscientious objections. I guess so it would be good to hear your thoughts on the clause in the bill. Is that clear enough? Who do you think it applies to? I'd also like to hear your thoughts on whether that should extend to organisations such as your own, potentially, to be able to say we're having nothing to do with this bill as an organisation. And we've seen some international examples of variation, particularly from Australia, around institutions opting having a conscientious objection to the legislation there. So just, I guess, in that wide sense, just to hear your thoughts on conscientious objections and institutional objections. So, Stephanie?
Yes, I mean, we as an organisation have tried to focus on the text of the bill, and you know, our service provision is about supporting people to live well and reach their potential, and that would not change whether or not this bill was or wasn't enacted. On conscientious objection, I think what would concern us is doctor shopping, and so, you know, you then end up in the sort of, well, if my doctor won't do this, how do I get to another doctor? We're concerned about the inequality, therefore, geographically, or, you know, the difficulty for people who already have movement, have difficulty with movement, actually travelling to wherever they need to go to, if that was the case. And I think the real underlying concern then is, could as the wording stands, somebody go through the process and with medical professionals who neither know them nor know about their condition, and that would be a big concern for us. So, you know, I think the bill doesn't say a huge amount about conscientious objection, other than that they can, and that, you know, so I'm not going to say any more about that from the medical professionals' side, but from the individuals, the concerns are as I've laid out.
Vicky?
So, with respect to conscientious objection, we believe that the best placed individuals to be able to respond to that would be individual practitioners and also their representative organisations and the wider bodies that they perhaps work for. So they would be best placed to do that. In terms of institutional objection, I can only really speak from an Alzheimer's Scotland perspective. From that perspective, we are a membership organisation. We represent around 8,000 members across Scotland. I'm sure you'll appreciate that views on this bill are quite polarised on both sides of the debate. And it's not for us as an organisation to come down on one side or the other in favour of one side or the other. So we would maintain a level of neutrality around that and leave decisions around institutional objection to others who may wish to form a stronger view one way or the other.
Thank you. Susan?
Really just reiterating what Vicky said in terms of institutional objections, just, our neutrality. We feel as if it's very much a personal choice for individuals, so we haven't come and, wouldn't be giving opinions on in favour or against.
Would there be any concerns from any of you if, obviously institutions which are opting out in Australia, for instance, are things like hospices, care homes, particularly when they're being run by, in Australia there's a lot of religious organisations run these, and in some states in Australia they're able to opt out as an organisation. Would that cause any concern about, obviously the folk who live within that institution, who are under the care of that organisation, then not being able to access the legislation?
I think from an equity and accessibility point of view, then, depending on the spread of any objection or choice to remove yourself from enacting the provisions that would be set out in legislation, I think then there are, if the bill is to be enacted, then certainly we would need to consider, making sure that there's fair and equitable access for everyone, regardless of where they are. So there would be a requirement to look at, what is the spread of access? How is that being done? Does that disadvantage or discriminate against any particular groups or communities? So it does ask wider questions, unfortunately, questions I don't necessarily have an answer for, but certainly,
good, though, thanks.
Certainly asks.
Susan or Stephanie or you? No. Okay, thank you. That's convenient.
Paul Sweet.
Thank you, Convener, and thanks to members of the panel for their contributions so far. I just want to turn to section 15 of the bill, referring to assistance. Assistance in the face of the bill as currently drafted defines assistance as providing the substance to end the person's life, staying with the adult until they have decided they wish to use the substance, or removing the substance if they decide they do not wish to use it. The bill does not explicitly provide that the substance would have to be self-administered, but self-administration is stressed in the policy memorandum and explanatory notes. I know certainly MND Scotland has referred to this concern as part of its written submission about, is the bill sufficiently clear whether people with physical disabilities who would find self-administration difficult or possible with a progressive condition like MND would have be able to have access to an assisted death. I just wondered if you might want to start us off with just your concerns about that definition.
So that's really what we've focused on in terms of all of our evidence, because, as I say, we are neutral, but this is an issue that we feel that we have had to address, because we do feel that if self-administration is the only option, then it will impact on people with MND being able to access assisted dying for the reasons that I outlined earlier, in that it's a progressive, debilitating illness, and it's very, very quickly progressive. From the outset, people can struggle to use their hands. Other people can struggle to speak and to swallow. So really, in terms of self-administration, it is a concern. And as Stephanie touched on earlier, there's not a lot of detail about, of course, what that would look like, but it is a real concern, and it is something that jumps out, that you could have, quite a large population that are unable to access it. And the concern that I raised earlier as well, just to reiterate that, is that it means that if self-administration is the only option, people could feel they have no alternative but to access an assisted death much earlier than they would choose to, so that they are actually physically able to do what is required of them.
Interesting. Do any other members of the panel have the comments on the current drafting of this section of the bill?
I would agree with Susan, and again, you know, people with cerebral palsy can experience reduced dexterity and or swallowing difficulties, and you know, would struggle to ingest medication. I think, you know, it's not clear what self-administration actually means. So I talked about head switches and things earlier, so clarity would be great. The other thing, it's very silent on what should the medical practitioner do if something goes wrong. So, you know, what is the medical practitioner, either in the room or not in the same room, meant to do?
That's an interesting point. Ms. Cowell, have you got any points to add?
So just to reiterate those points, that, you know, potentially there's room for you know, those with physical impairment or perhaps cognitive impairment, which might affect coordination, for example, might create issues around fair and equitable access for those that are able to satisfy the other criteria to reach this particular stage in the process. Again, it's about supporting individuals to exercise their autonomy and looking at how we do that. So that could be, for example, through alternative approaches. So rather than, for example, tablets, looking at liquid forms or other supports like the head switches or finger switches for individuals. So certainly that's something that should be explored in terms of how that might meet itself out in those examples. And again, I would go back to that that question around, you know, making sure that part of that capacity is the ability to act. So actually being able to self-administer requires that ability to act. So the legislation needs to kind of come back to that in terms of doing that. Any suggestion that there's intervention by another individual in any way, shape or form might potentially change the scope or the parameters or the intention around the bill. So any suggestion that, you know, there's any other type of intervention is something that would need to be very much considered in terms of whether it falls within the intention of what's already been set forth.
Really appreciate your initial thoughts on that. Section 15, Part 1 of the bill does simply make this mention that it's about someone providing a terminally ill adult with an approved substance with which the adult may end their own life. The UK bill does contain more detail on what is permitted within this definition of self-administration, and it says the coordinating doctor may prepare that substance for self-administration by that person, prepare a medical device which will enable that person to self-administer the substance and assist that person to ingest or otherwise self-administer the substance. Would you like to see the bill amended to have that level of detail or something similar? Is that what you're essentially asking for?
Well, we're not really asking for anything.
Right.
We're just really asking for an awareness that if the bill stands as it is, you could exclude a lot of people. I mean, obviously, I've listened to previous evidence sessions, and you know, obviously, well, that's included in the English bill. Other countries, maybe for people who can't self-administer, they are permitted to seek medical intervention in the process. We wouldn't see what should be done. That would be a decision for people around the table to make. But clearly, if it is at the moment, as far as we can read, it will exclude many, many people with MND. So, as I say, that could be more detail in self-administration or in special circumstances for a medical professional to get involved. That would be something for you guys to decide.
Okay, thank you. Just wonder if there's any other final comments on the need for amendment to improve the definitions. Okay, that's fine. Thank you, Convener.
And Sandesh Gohani.
Thank you, Convener. Vicky, can I just touch upon some things that you said so far, and just following on from Paul? I'm not clear whether you would like to see tighter restrictions on assisted dying or whether you'd like to see greater access. And I was just wondering if you could help me understand.
So the purpose of the evidence that we've put forward is to present both sides of the argument, and ultimately it's for those here and our parliamentarians to consider and look at those options. So we choose to neither support nor oppose the bill, but what we have decided to do is raise those issues and concerns that might come about if there is a decision either to include or exclude people with dementia. So again, we are happy to engage further based on any amendments that might come forward if the bill moves through the legislative process and moves on to further stages beyond kind of stage 1 as we are currently at. So we choose to support neither option, but more to reflect that there are opportunities in both directions depending on what decision is made in terms of how the bill progresses or does not progress.
Thank you. Can I thank all three witnesses for their evidence today? It's certainly been very helpful to the committee in its scrutiny of the bill, and I'll briefly suspend the meeting for a changeover of witnesses. We now continue our scrutiny of the Assisted Dying for Terminally Ill Adults Scotland Bill with a second panel of witnesses from organisations representing individuals with disabilities, and I welcome to the committee Teresa Burke, Chief Executive Officer of the Glasgow Disability Alliance, Lynn Pornarno, Chief Executive Officer of Disability Equality Scotland, and Marianne Scobie, who is the Deputy Chief Executive Officer of the Glasgow Disability Alliance, but representing the Glasgow Centre for Inclusive Living today. And we have both Teresa and Marianne joining us online, and Lynn with us here in person. And we'll move straight to questions. And David Torrance.
Thank you, Convener. Good morning, everyone. Do witnesses think the current definition of terminal illness in the bill is sufficiently clearly drafted to only apply to people with terminal illness?
Anybody going first? No. That's the answer. No. Whenever there's a definition, it leaves open to interpretation. I'm sure that we all know individuals who have been given a terminal diagnosis and given an estimated time of their remainder of their life, and they have survived much longer through different treatments, through new treatments becoming available perhaps, or just their life lives longer. So no, in a simple term, no, it's not clear. There has to be a definition. If there's going to be a definition, it has to have no ambiguity to it. There has to be no way that somebody can interpret that in a different manner or not. And when we're talking about people's lives, it is people's lives we're talking about. Therefore, as our medical professionals who estimate length of life, etc., then they sometimes get it wrong. They will say that themselves. They will sometimes get that wrong because we don't know when people are going to, their life's going to end in that manner. So no, it's not strong enough. It's not clear enough. And we asked our members as well, Disability Equality Scotland, around that question. And even within that, there was different people. It could mean this, or it could mean that. It might be that. It might be this. So straight away, it needs to be really tight and clear around there. And I'll pass to my colleagues then to see what they say.
Teresa, would you like to start?
Yeah, thanks. I suppose just building on what Lynn's saying, I completely agree. Glasgow Disability Alliance members were concerned that the definition was something that would apply to many disabled people. I know that Mr McCarthy has given some reassurance to some DPOs that that we should be aware that it would allow only those with advanced progressive terminal illness and mental capacity the choice of accessing an assisted death. But we weren't aware, as the language used in the bill's definition of terminal illness makes no mention of advanced and progressive terminal illness. So we felt very much that that definition could apply to disabled people. Glasgow Disability Alliance is a pan-impairment organisation. What that means is that we have members, almost 6,000 disabled members, spanning a full range of conditions and impairments. So there's many disabled people who are born with impairments, but many, many more acquire illnesses and conditions throughout the lifespan, possibly through strokes or accidents or cancer or conditions like my own, MS, motor neuron disease. I know that was covered in the previous session, or certainly the organisation representing it. So there are so many conditions that could fit with this definition. And the worry that we have at this point is that discrimination and prejudice are endemic in society, and despite any best effort, no law is immune from that. So we're very concerned that the definition is too wide and that many disabled people will fall under it.
I think Marianne wants to come in too.
Thank you. Thanks. I would absolutely echo what Tressa and Lynn have said in relation to their organisations. GCIL, Glasgow Centre for Inclusive Living, also feels that the definition is not correct and is not understandable enough. And also that the definition of terminal illness would apply to many disabled people who have life-limiting conditions that they're unlikely to recover from and would be reasonably expected to cause a premature death. I think it's also fair to say that many disabled people themselves, as Tressa said, we're also a pan-impairment organisation. And within the bounds of the Equality Act, people with terminal illness are also defined as disabled people. And many disabled people develop terminal conditions because of comorbidities as well as their actual existing conditions themselves. Studies have shown that doctors and health professionals are not actually that accurate at predicting how long someone has left to live, and the accuracy can range from between 23 and 78%. So it's quite a wide level of accuracy or inaccuracy in relation to predicting how long someone has left to live. And many people live with terminal conditions for many months or even many years. And we're concerned that people might make decisions to end their life based on an inaccurate prognosis of their condition and their situation without any mental health or other support to enable them to process and cope with their diagnosis. And many people, when they're given a diagnosis, their immediate thought is, I don't want to live anymore, I'd rather die than go through a terminal illness. But actually, with the right support in terms of healthcare, mental health care, and peer support, many people can actually live with a terminal condition and live well. So we would be promoting the fact that people should be supported to live well while they're dying, including with a terminal illness. And we're further concerned that people might, that the legislation might widen out to include people who are not terminally ill. And I'm sure that's something that we're going to talk about anyway. Thanks.
Thank you. Many of submissions against the bill say it would be a start to a slippery slope. Do you think the bill, if passed, could be expanded to include people with disabilities without Parliament oversight? And if so, are there additional safeguards you'd wish to see that could prevent this from happening? Lynn?
Yes. There's been talk about other countries who have a similar type of bill passed, and there's some argument to say, well, we can't look at other countries because those are other countries, they have different laws, etc. However, when you do look at those countries that have brought in some kind of assisted dying type bill, it has been expanded. Whether or not that could be expanded officially without Parliament scrutiny and gone through that, I would hope not, because I would hope none of our bills actually would be allowed to be amended without that happening. Concern for our members and disabled people's concerns is that, as with everything, there is a little bit of, what's the word I'm looking for? Sorry, quite tired today. Interpretation of laws, of bills, etc. And we see that all the time. Disabled people are concerned that their options will be more directed towards assisted dying rather than looking at palliative care, looking at the terminal illness, whatever that definition ends up being if this goes through, and that it's a small sidestep to, well, maybe it's not a terminal illness you have, but it's something that is, causing you challenges perhaps in life, and maybe this is an option, etc. We're all aware of situations during COVID where a lot of disabled people had do not resuscitate messages put on their files without any consultation, without approval, etc. And in fact, we heard about one that happened just recently, an individual who did not have capacity who had that put on, because doctors had asked the question, the person had said, yeah, that's okay, and not really actually consulted the legal situation. So those slippery slopes then become the norm, and it's so much easier then to widen that out. And there's a lot of evidence for people who have lived in other countries who've been offered assisted dying as an option through that slippery slope, who've refused it and who are now against the whole option of that wider area being allowed to progress through.
Any other witnesses?
Thank you. We're absolutely certain that there will, if legislation to legalise assisted dying is approved, it would very quickly open the door to widen the scope of the eligibility criteria. And we've seen that in other countries where assisted dying is legal, eligibility has widened out to include children and young people as well as other adults. And it may not be that the legislation itself is widened, but certainly the practice and the implementation of the legislation is widened. So we firmly believe that legislative creep is an inevitable consequence of legalising assisted dying. Campaigners for assisted dying highlight the personal stories and the tragedies of disabled people's lives to promote the assisted dying cause, and there's clear evidence that disabled people's lives and lived experience have been used to promote assisted dying by campaigners putting forward that legislation. And I think it's extremely naive and dangerous to expect that those campaigners would be satisfied with the eligibility criteria as proposed in the current bill. We saw quite recently with the Westminster vote that really very, very soon after the vote, there were already calls to widen the scope of the legislation and reduce safeguards, such as the need for a judge to make a ruling. Those not eligible in the original legislation might claim that they're being discriminated against as they're prevented from accessing assisted dying, and we heard some of that in the earlier evidence session. And that would include people who cannot self-administer drugs, so that would open up the scope for people currently excluded, including disabled people. And it has been shown in every other country or state where assisted dying is legal that the guidance and the implementation has been widened. So there's no reason to believe that that wouldn't happen in Scotland. And when we already see other pieces of legislation in Scotland that seem quite tight on paper, but the way that they're administered, the way that they're put into practice is not. And I would point to self-directed support legislation as an example of that. So there is numerous examples of eligibility criteria being widened. For example, in Oregon, cancer, although it remains the main qualifying diagnosis, it's fallen from an average of 80% in the first 5 years to 64% in 2022. But other diagnoses have been listed as making people eligible for assisted dying, such as arthritis and other non-terminal illnesses, and also people who are experiencing extreme socio-economic disadvantage, such as homelessness, and people who have been unable to find mobility equipment, and so on and so forth. The other thing that's happened is that the doctor-patient relationship timeline has lessened. So it's gone from 18 weeks to an average of 5 weeks in 2022. And that means that sometimes people might be doctor shopping in relation to finding a doctor that would be able to classify them as eligible. And that shows that the safeguards just become widened and nullified over time as well. So it's our opinion, and it's the opinion of all of the DPOs in Scotland that legislative clique would be an inevitable consequence of enacting such legislation for assisted dying.
I think Treza wanted to come in on this point as well, David.
Thank you. Yeah, can you hear me okay? Thanks. So simply put, as Marianne said, as with Glasgow Centre for Inclusive Living, as with Disability Equality Scotland, and I know Inclusion Scotland as well, and other DPOs, disabled people are incredibly strong in their opposition to assisted dying, because we do feel that we will be the ones at the thin end of the wedge when it comes to assisted dying. And I know that this kind of crosses over into maybe other areas, but what Marianne touched on there, you know, during the pandemic, certainly Glasgow Disability Alliance members were so terrified at what happened with do not resuscitate orders being found on their medical notes, or certainly being asked to cooperate or comply with these and not fully understand what it meant. Very inappropriate conversations at very inappropriate life stages, which were not at the point of terminal illness or end of life, and the relegating of disabled people's lives to be of so little value. And the attitudes that were very apparent and increasing were that, you know, it didn't really matter if disabled people died because we were already vulnerable. When we were hearing reports of who had been dying every week about COVID, there was analysis saying, you know, those people might have had an underlying condition, or they were old, they would have otherwise not enjoyed a good life or a full life. And this is what has made disabled people feel less of worth less. That our lives had less value and less currency and less meaning. And this evidence was enough for our members. At that time, it was 5,000, and now, as I say, it's approaching 6,000, to take an actual approach of campaigning and lobbying us to do work around assisted dying. And we ran workshops, we showed films, and we did what Glasgow Disability Alliance does and what the other DPOs do. We provided support and information so that people could have space to talk, ask questions, find out information and deliberate on this really emotive subject. So unlike some of the organisations earlier, we have a very clear stand against assisted dying for this reason, because we simply believe that it will creep, that disabled people will be the thin end of the wedge, and all the threats that are coming just now, not just the austerity and the cuts to services and COVID and then the cost of living, but now the ruthless warrants we're hearing about cuts to disability benefits, are making disabled people feel that they will be the thin end of the wedge.
Liam MacArthur.
Thank you, Convener. I'll not touch on the arguments around slippery slope, where I think all the evidence is that there isn't a jurisdiction with a terminal illness mental capacity model that's seen the eligibility criteria expanded over time. But rather the point that's being made that disabled people are uniformly against assisted dying. All the polling evidence suggests that the support amongst the disabled community as a whole broadly maps the position of the population at large. And I'm aware that Disability Scotland back in 2022 undertook a survey of their membership, which showed strong support amongst 57% and support amongst 20% of members, in opposition solely just over 10%. So I understand that there are anxieties within the disabled community, but I'd be interested in the witnesses' response to the argument that support or interest in finding out more about this issue is unlikely to be helped if the view that's presented of the legislation comes from the perspective of opposition as opposed to challenging neutrality. And as I say, in light of the position that members of the disabled community appear to take to this issue, is that not a more reasonable way of eliciting the views of disabled people? I can put that to Tressa Burke because she spoke last, but I'm sure others will have a view on it.
Thanks, Liam, for your comments there. I think I can understand that a lot that is driving the agenda for assisted dying amongst many people will be about compassion, about the end to unnecessary suffering, about people's autonomy and choices at that particularly difficult point of life. I think for disabled people, I mean, I would struggle to believe that Glasgow Disability Alliance members would have the groundswell of support you're describing. I know for a fact that the people that we've engaged have been universally against it. And I'm not saying that that's unanimous there are very, very small numbers of people, and it's a handful of people in meetings that we've spoken to, never more than one person amongst a couple of hundred at a time who might have concerns for just exactly the reasons that you're stating. But we believe that disabled people's lives have been so devalued, so deprioritised. I mean, during the pandemic, disabled people, you know, when we were speaking to people at wellbeing check-ins, we uncovered that, you know, 90% of our members at that time felt lonely and isolated. People were concerned about their access to services. 55% who participated in a particular mental health piece of research expressed having suicidal feelings in the past 2 years, and there was a whole range of exclusion uncovered during that time. We then repeated a survey, a very in-depth survey of 30 questions for disabled people who were members of GDA, and it was restricted to our membership. 621 people responded to that survey, and people spoke about feeling forgotten about by governments. They spoke about having concerns around money. That was 93% of people, with about 71, I think, percent saying that they couldn't afford to manage their bills. 91% were experiencing social isolation and loneliness, and 89% of people were experiencing difficulties with mental health. But I think the really overwhelming stat, because these are stats, the really overwhelming fact, and the fact that there are people behind all of these statistics, is that people don't know where to get support, aren't able to access the services and supports that they need. Where there are services, they're often available but not accessible to disabled people. So disabled people are experiencing exponential interrelated barriers that make their lives sometimes feel not worth living. So disabled people feel that they would be the thin end of the wedge, as I was describing, for all of these reasons. I don't think that there are any safeguards that we feel that could be put in place because of the slippage in other countries, because of the evidence that we're seeing around us about austerity. I mean, when things get tough for governments get tough on disabled people. And if we hadn't seen the evidence during COVID, we're seeing it with the cut of the winter fuel payment by the UK government, and now the threats to benefits specifically for disabled people by the UK government. And unfortunately, that's often replicated across the devolved administrations in terms of cuts, just because the money is so tight. So when we are saying that we're concerned that we're at the thin end of the wedge, we are using evidence to say that. We're not just saying it as a gut feeling or a sense of intuition. We're saying it based on the evidence of extreme disadvantage, of disabled people dying not just of COVID but of health inequalities. I cannot tell you the number of funerals that I've been to over the last couple of years, partly COVID but partly health inequalities and sometimes suicide of disabled people taking their own lives, not because you know, they necessarily were in that state of mental ill health before, but because the cumulative impact of not having the services and supports that they need, and the isolation that they experience, is so bad that their lives become unbearable and not worth living. But the disabled people that we have who access, for example, the Independent Living Fund and get the support that they need to live the lives that they want to live, tell a very different story. And what we want is service and supports for disabled people so that everybody can enjoy that kind of life.
Brian Whittle.
Thank you. I'm listening, obviously, you know, very passionate, Tressa, on your views. But I'm wondering whether or not it's a comment more on not so much this bill, but your comments more about the way in which currently society is treating disability and disabled people in terms of access to services, the way in which governments potentially are treating disabled people. It's more of a comment on that rather than the specificity of this bill. Would that be fair?
Thank you for your question. So I would say two things. It is both a comment on the bill and a wider comment about disabled people's place in society. Disabled people historically are put to the bottom of society whenever there are problems, whenever the money is tight. As I say, when things get tough for governments get tough on disabled people. But we are also concerned about the bill, about the potential widening, about the definition not being clear enough. I mean, we're probably unlike the organisations this morning, we're not neutral. We are not saying that when the bill gets through we want to work with you on the wording of it. What we're saying is that the timing is completely wrong, and how can we, at this time of extreme austerity, of all these cuts to services, of the fact that we're on the phone to social workers who are crying because they can't uphold disabled people's rights, and in fact they are being forced to erode disabled people's human rights, the very people that got into a job, and I say that as somebody who trained in social work myself, who got into it to try and uphold rights, to try and make lives better, are actually having to undermine that. How can we be introducing a bill like this at this time, when actually what we should be looking at is how to help people live a better life, and we should be looking at investment in public services and in palliative care and end-of-life care and support as well.
On this point, Marianne, on Mr Whittle's question.
Thank you. I think that what's important to remember from our perspective is that, like Tressa said, there are very few disabled people as part of our organisations who've said that they supported the bill. But when we've asked them why they support the bill, it's because every single one of them have said it's because I don't want to be a burden on my family. Rather than they fear dying in pain or suffering. They talk about they don't want to be a burden on their families, which is completely different from the intention of the bill. And people, because of the current situation that they're living in, that's the reason for asking. I do want to mention the previous surveys, because I think it is important to clarify that. Lynn obviously is the chief exec of the organisation that grew, that came from the previous organisation that you mentioned. That organisation no longer exists, and when that survey was completed, we did, as a group of disabled people's organisations, interrogate that data, and there was actually no way to check back on whether or not it was disabled people who were members of the organisation who'd completed that survey. And similarly with other surveys, 60% of disabled people face digital exclusion, which means they're not able to go online and put forward their views in surveys and online, comments and so on, including in relation to this particular bill. So disabled people are actually disengaged from being able to participate in capacity building and in relation to understanding, the views of these bills, of the bill and this particular bill. So disabled people cannot put forward their views in a way that that other non-disabled people can, because they don't have the information and they don't have the skills, capacity or the opportunity to contribute. So the reason that our organisations have become opposed to the bill is because we've done significant in-depth capacity building with disabled people, presenting all sides of the arguments, helping people to discuss and debate, deliberate their views and opinions, and come to these conclusions. So we absolutely have supported disabled people to come to these viewpoints, and it's because of the strong views of disabled people that our organisations come to these views. There's also other surveys that have taken place in relation to disabled people's organisations over the UK, and again they were quite disingenuous in the fact that if organisations didn't have it on their website that they were opposed, it was assumed that they were either neutral or pro the legislation. And so some of the surveys that have been published actually do not present the real genuine views of disabled people and their organisations. And if I can finish on another point, is the fact that when we do speak up, we are targeted for abuse. So many of us are involved in campaigning, outside of our organisations or as part of our organisations. And when we speak up, particularly on social media, we then are targeted personally for abuse and harassment and quite hostility in relation to our views, which makes us quite reluctant to speak up. against this sort of legislation. So I think that we have to think about the fact that disabled people want to have their views heard. They want to be part of the collective voice of disabled people as part of their organisations, and some of that's about protecting themselves from abuse and harassment when they do speak up as individuals. So I think that we just need to remember that that's the reality for disabled people. And Tress and I are here online today because we're not fit and able to actually appear in person. And again, that means we are confident, articulate, disabled people who are leading organisations, and yet we are not able to be there in person. So we can't always present ourselves in front of you, apart from being online. So it's really, really difficult and challenging for disabled people's voices to be heard, and I think that we need to remember that. Thanks.
Thank you. Emma Harper.
Thanks, Convener. Good morning, everybody. Thank you, Lynn and Tressa and Marianne, for being here this morning. It's on a similar kind of trajectory. I'm thinking about autonomy, and we've just talked about definition of terminal illness. I remind everybody I'm a registered nurse, but I'm thinking about the bill is designed to apply to individuals with a terminal illness, and the definition might need to be altered for that. How can we address the concerns of disability groups while respecting the autonomy of those seeking to access assisted dying? I'm looking at Lynn first, but only because you're in the room, and I'm sure Tessa and Marianne might want to answer.
Happy to speak with that. I think what we need to look at is we need to look at disabled people's lives in full. As with any citizen in Scotland, we need to look at their lives in full. And, opinions and thoughts change as people develop new knowledge and understanding of their conditions of terminal illness, etc. When we held a focus group in last year with members, and we had phone calls, etc., with them as well. And one of the things that they were clear about for those individuals who said that they were supportive of the bill, subject to, and it was always subject to there being sufficient safeguards that the autonomy of individuals is upheld. Exactly. One of the quotes from somebody was, persons living with disabilities are not having their rights listened to currently, and their views and rights regarding assisted dying then may be ignored or not even asked about. And that was kind of a concern with regards to that. For the autonomy, we need to consider a whole raft of that, starting from individuals who receive a terminal diagnosis, and as Tressa mentioned about that time to kind of absorb that news first of all and understand what that may mean for that individual, etc. Concerned about individuals who don't have capacity but are seen as having capacity, and others who are not seen as having capacity but do. And then the autonomy around making the decision, but also going through the process, having conversations, and then actually, taking the medication, whatever that looks like at that point in time. What about those individuals who physically can't administer things themselves? What if they're changing their mind, etc.? So there's a whole rasp as individuals, as we do in our day-to-day lives. We have different thoughts on different days. We have different opinions sometimes on different days about things. And we need to have, our members felt clearly that there needs to be something around reasonable adjustments being allowed in the bill for those people that can't perhaps administer medication themselves. We have one person saying that there needs to be the opportunity for people to make the health decisions for themselves, and the right choices by keeping them informed and by not just this is an option for you. This is roughly what happens, and make your decision. There needs to be support. There needs to be counselling around things. There needs to be helping understand what other options are available to them as well. And that's a concern that some of our members had, was that should this bill come into place, it will be a case of that will be the automatic option rather than other options being available, palliative care, support, treatments, etc. And there needs to be a position between a specified amount of time between receiving that diagnosis and actually requesting, if should it go ahead, requesting the assisted dying. There needs to be ensuring that there is full understanding of what this means. We talk about choice and we talk about control, and we absolutely should have that. However, our choices are not usually so final. In life, we have choices. We can then change our mind and come back, etc. Whereas this is a final one. And one question that we had brought up, which then our members all had a big discussion about, was around what is unbearable suffering and dignity. That will change for every single person, and it will be different, and that's where our discussion went through. So how do we determine what is right for one person may not be right for someone else? And if we're looking at those definitions again, how can we, when someone is going through suffering due to their terminal illness, their condition, etc., on one day they may feel like it's unbearable, the next day it might be a different scenario.
Okay, thanks.
Marianne.
Okay, thanks, convener. Marianne.
Thank you. Thanks. I think we would say that it's difficult to truly make an informed decision about your own care or treatment when they're limited from the beginning. And it's difficult to make a choice when you're not supported in the right way in relation to your mental health. Like Tressa said earlier on, 55% of disabled people that GDA surveyed said that they'd had suicidal thoughts in the past 2 years. And what's important about that particular survey is that was a survey of disabled people who didn't have a diagnosed mental health condition. That was disabled people who were experiencing mental health challenges, and it also excluded people who were currently in a mental health crisis. So that's a really important thing to consider. And our lives as disabled people are portrayed as tragic and worthless all the time in TVs, literature, media. And many people start to internalise those feelings that they'd be better off dead if they can't walk or talk or feed themselves or go to the toilet. And many people who become disabled through illness or accident, including terminal illness, don't receive the mental health support or access to peer support to enable them to come to terms with that diagnosis. And there are no mental health assessments within the bill, as far as we understand. And we've seen from the review of what's happened in Oregon that, over 25 years, just 1% of those opting for assisted dying there underwent any psychiatric evaluation. And many of the members of our organisations tell us that they've contemplated or attempted suicide prior to joining the organisations because they feel that their lives are not worth living. And a lot of that is due to the fact that people are forced into living really undignified lives. Someone saying, I've been forced into using adult nappies even though I'm not incontinent because my social care package has been cut so much, and we see that more and more often. And many disabled people, as I said before, who say that they might support the bill, say that they're doing so because they don't want to be a burden on their families. And we would argue that that in itself demonstrates that disabled people would be affected should it become legal, because supporters will push for eligibility extensions, and that lack of support not being available to disabled people further intensifies the burden that disabled people feel. So I suppose, in short, when someone's life is so dire and so tragic, it's not a choice when you feel you have no choice but to opt for assisted dying. And as a society, we should be we should be prioritising assistance to live well and to die well with the support that we're needed, but not actually assisted dying from a medical perspective. We should be prioritising funding and resources for health and social care, and in particular for palliative care, so that people can live and die well without prioritising medical assistance to end life. Thanks.
Okay. I've just got another final question. In the witness's view, is assisted dying any different in principle from a person's right to refuse treatment and interventions such as artificial hydration and nutrition? In my experience, looking after people at the end of their life, sometimes people do choose no further methods that would support them, like subcutaneous fluids, for instance.
I'm just getting the words right in my head to answer you there. Yes, people have a right to ask for no more fluids, etc. Sometimes that's forced on them as well. However, they also have the right then to turn around and say, actually, no, I do want fluids again, etc., or food or medication, etc. And they are choosing at that point to go through a natural death and allow their body to kind of survive as it will for as long as that needs to be. We hear the message that assisted dying is an option for people. And I think, it's been spoken about as a treatment option. It's not really a treatment option. It's an option to end someone's life, and that suicide, people choosing to take their own lives, causes so much pain and distress for family members, etc. This is no different. We spend quite a lot of time, energy and money within Scotland to prevent suicides. And it feels incongruent then that we're turning around saying, but you can also then choose to end your own life in this manner. Also the choice that people are making when they decide that they don't want any more treatment, that they don't want any further assistance, whether they're in palliative care or in hospital or at home, are also faced with the fact that they know their death is absolutely 100% imminent within more than likely a few days or a week or so. Whereas with the bill, we're talking about you receive a terminal illness, a diagnosis with 6 months to survive, and then you've got that choice of when that's actually going to be. We either, as a society, are acknowledging the sanctity of life, or we're coming away from what makes us human, actually. And disabled people have that fight on their hands for some people from the moment that they're born. And they have a fight to get the support that they need, to be heard, to be listened to be valued, to be educated sometimes, to live life as non-disabled people do, to have the opportunities and the fairness there. And they are neglected, they are had their human rights taken away from them. I mean, we can't even as Scotland incorporate the full rights of disabled people into our laws because of challenges that are faced there. Do we have the right then to turn around to recommend that people, because that's what will happen, we recommended for people to consider an option, and that's how it will be presented, consider an option, rather than go forward and make that choice when they know things are imminent to refuse that. Now, we also know that sometimes at end of life, as you said, some people refuse further treatment, etc. Sometimes that's forced on people, and sometimes even though people are refusing, they're still receive hydration, etc. as well. So we know that the There is no perfect solution out there for individuals around their end of life. We also know there's no perfect system as well. But if we've already got systems that don't uphold individuals' rights, their autonomy, their decisions that they want to make, then how can we bring in something else that is going to, again, still even more so be so final to allow people to not have their rights and their wishes to be upheld in that regard?
Okay. Teresa, I believe you want to comment on that?
The question of autonomy, but it also relates to this. Just in terms of considering autonomy, autonomy is, broadly speaking, about being able to act without influences, without other influences to have to consider. And we feel that the bill is absent on the impact of structural inequality, all these things that we're talking about, those living with long-term or terminal illnesses, whose decisions could be influenced by the reasons that have been outlined about the need for support, about the barriers in getting the support that people need to live a full life and participate in society, about poverty, exceptional poverty. And we know just now that 62% of disabled families are more likely to fall into deep poverty. 25% of people are having to sell household belongings to make ends meet. 70% of disabled families, according to Joseph Rowntree Foundation, have had to cut back on essentials. So these are external influences, but they're very much factors that might influence disabled people to take a decision about assisted dying, as opposed to tackling the structural inequalities and helping people to live.
Thanks.
Sandesh Kohani.
Thank you. Just a declaration of interest as a practising NHS GP. Can I turn to the people online? From what I've heard, there is a universal opposition from disabled people towards this bill. And Teresa, you spoke about gross societal inequalities for disabled people. So if the bill were to pass, or before we go to that stage, would you like to see an amendment put in that specifically excludes people with disabilities from being able to access assisted dying?
I need to actually give some thought to that, Marianne. I wonder if you would have a response to that.
I think your question is an example of why legislation would quite quickly be opened up to legislative creep, because what would happen is that if you exclude disabled people from being able to participate in it, then you're creating a discrimination against disabled people. And so at the moment, when we're talking about our organisations, we're talking about disabled people who are connected to our organisations, who've had the time and the capacity and the support to recognise the discrimination that they face, to understand the social model of disability, which is basically talking about the fact that the barriers that we face as disabled people are not ingrained in us, they're actually society's barriers. So sometimes when disabled people don't understand their own oppression or don't recognise, the discrimination that they face, they may feel like they'd be better off dead, and many people do feel like that. But when disabled people actually begin to understand that the social inequality that they face, the structural inequalities that they face, actually are not their fault and can actually be addressed by policy and governments doing things differently, their opinions change. So it's difficult,
Can I just go back to the question, though? So you've certainly, you've made your point very clear about the structural inequalities and the real problems that are facing people with disabilities. But my question wasn't about creep, or wasn't about what could happen. It was specifically about whether a member of the Scottish Parliament should introduce an amendment to specifically exclude disabled people from accessing assisted dying.
Yes, but what I was saying was, if you put in such an amendment, there will be calls for that, for it to be widened, so that disabled people who become terminally ill, for example, would be excluded from. So how can you possibly have an amendment that says disabled people would be excluded when people who are terminally ill are by definition within the Equality Act disabled people? So it actually cancels out. So when someone has a terminal diagnosis, they're defined as disabled people within the Equality Act. So you can't possibly put in one piece of legislation to exclude disabled people. It doesn't make it. That wouldn't make any sense. It wouldn't fit from a legal perspective.
Okay, so you wouldn't want to see an amendment put in then?
We don't want to see the legislation put forward at all.
Okay, sorry. Teresa, perhaps could I ask you specifically about my question, whether you feel that we would somebody could put an amendment in to specifically exclude people with disabilities?
So thank you for the question. And again, I hesitated because what was in my mind was exactly what Marianne said. How can you exclude disabled people when the definition of disabled people would include people with terminal illness? So it was really more that I was confused by your question, although I think I understand the sentiment of what you're saying. I think the problem with that would be that it would create inequalities, and the unintended consequence would itself be discriminatory, and that might be problematic from the point of view of the Equality Act as well. So I think it's a technical problem that would arise from it. But as Marianne said, our position is we would rather not see the bill at all rather than an amendment.
Okay. I think, then if I could turn to you, when we talk about the bill itself, you talked about the sanctity of life, and that seems to me to be a religious discussion and argument. Is that your position about the sanctity of life, or was that just a turn of phrase?
It was just a phrase that, as a society, part of the Western world, we've always upheld life. Within our medical professionals, the Hippocratic Oath, I think at some point talks about, upholding and do no harm, etc. It's about life is important, etc. It wasn't from a religious point of view. It's the fact that life is, we're all valued. We should all be valued. Our lives hold value regardless of who we are or our whether we're disabled or non-disabled, etc. And therefore, every life, as far as I've been brought up to know, and from what I've experienced in Scotland here, is that we all have value to bring, etc. And life is important, and I'm not sure why we would spend so much time trying to prevent people from taking their own lives, from committing suicide, and following that through. And preventing people, as we see the scenarios, if we saw someone in distress and who looked as if they were going to attempt to take their own life, we would do all we could to stop that and to give them support, etc. So how can we do that if then, on the other hand, we're saying it's okay to kind of end your life? That's where I come from that sanctity of life.
Okay. And my final question, if I may, convener. Just now we've received an email from somebody whose husband went to Dignitas in Zurich and is expressing their support for this person being able to choose what happened to them. Given that there's a opposition from disability groups, what would you say to people on the other side who would like this brought in for them, for their autonomy and their choices?
I can see the other sides. I think we all can. We have members who are supportive of the bill in principle, subject to sufficient safeguards, more definitions, etc. And we have other members who are totally against it. We had a very good focus group where people actually listened to conversations. We had some individuals who were living with terminal illnesses themselves, and again there was a mixture of viewpoints regarding that. How someone else lives and what they choose in their lives, I don't think any of us have the right to say you can or you can't do in that regard, and that's a personal viewpoint there. If this bill comes into effect, with regards to it, obviously that would be the law, so people would have that choice, as they have a choice of perhaps where they stay or what job they do or that kind of thing. And we obviously would support people. The argument is that as the bill stands at this point in time, disabled people, we can't just look at the bill on one thing. It's people's full lives, and when they have had these challenges that they've faced throughout their life or for a period of time, and as my colleagues have said, around the challenges they face around getting support, around getting being in poverty, about having barriers faced day after day after day, etc. That's the challenge that we have with this bill at this moment in time. Disabled people do not have the capacity often, for a variety of different reasons, to be able to fully understand and express their viewpoints, and they're often pigeonholed into square holes because we know what's best for you. There's the medical model that our society kind of adopts, which is wrong. It's seen as this is what is wrong with you. I'm here today. I've been a disabled person all my life. However, I didn't know that. Because I had long-term conditions that affected me according to the Quality Act, but I didn't know that. And I only actually really started talking to myself as a disabled person, or identifying as a disabled person, after catching COVID. And having breathing issues, and therefore not being able to walk any distance, etc. And from what I experienced through that, from what I would have said my challenges when I look back, what I faced over my life, the challenges were there, but I didn't always see them. And that's what Marianne was mentioning, that sometimes we don't see the barriers, the discrimination, the challenges that we face until it's kind of brought to our forefront and our eyes are kind of opened in that regard. So for individuals who are choosing to end their life, like this person who has emailed you in, and they've chosen to go to Dignitas, that's their choice. In this situation that we're in at this moment in time, we don't know what that person's life has been like. Have they been a disabled person? Have they faced adversity? Have they faced poverty? Have they been ignored? Have they had their dignity and their choice and their control taken away from them over and over and over again before they got to this point where they've chosen to go to Dignitas? We don't know that scenario. We are representing individuals who have had that choice and control taken away from them day after day after day, barrier put up, discrimination faced, abuse, as Marianne's mentioned, about standing up for their own rights, not necessarily about assisted dying, but any rights, and abuse put forward to them. And therefore, their choice when they're coming towards end of life is a completely different scenario for non-disabled people.
Thank you.
Thank you. I'm really conscious of time, and we've got a lot of questions still to get through. So if I can ask members to be succinct with their questions, and witnesses to please be succinct with their answers, that would be very grateful. And I'll move to Gillian Mackay.
Thanks, Convener. You'll be pleased to know I'll be keeping mine to one question. If I could go to Tressa first on this, if that would be okay. We've obviously explored already quite extensively the structural and societal barriers to disabled people, and as a disabled person myself, I totally recognise many of the things that have been spoken about. In terms of those structural barriers that we've spoken about, can services ever reach a point where the witnesses, and I appreciate this is potentially something you haven't been able to put to your members and might be in a personal capacity, but could services ever reach a point where the witnesses would be satisfied that a decision to have an assisted death was entirely free from pressure, and that the introduction of assisted dying legislation was at the right time for disabled people?
Thanks, Gillian, for your question. I think that's an incredibly complicated philosophical question that you're asking. I would push back and ask, could politicians ever adequately fund services so that the disabled people and people who need them across Scotland aren't in the dire straits and facing all these potential influence factors? But separate from that, I think there will always be risks around coercion. So at the best of times, if this legislation or this bill had been introduced, we would be urging safeguards around coercion, because coercion is one of the biggest fears that we've got. Obviously, the creep in eligibility being the number one thing, but coercion pretty high up there with all the things that we said. I'm not going to rehearse that again, but for all the reasons that we're saying. So I think if we could get to a place where there was more progressive taxation, better investment in services, disabled people being valued as part of society more equally, even more equally, rather than pretending that we're ever actually going to be equal, but more equally than we are. I mean, as one of the previous speakers said, we are so devastated that the Human Rights Bill has paused or gone back, actually, and that there will be no incorporation of UNCRPD, because in relation to Lynn's point, it's not for us as disabled people or DPOs, certainly not the three of us on this call, but maybe for some of our members, but for us it's not about religion, it's about human rights, and for our memberships it's definitely about human rights as well. It's about the protection of disabled people's human rights by the European Convention, by the UNCRPD, and obviously the erosion that we've described that's happened now for 15 years and it's got worse and worse. So I think that even at the best of times, there would be risk of creep and there would be risk of coercion, which I think is more what you're getting to, factors that are influential that would maybe make people make those decisions. We couldn't really ever fully know what that might be in relation to people who have limited capacity, whether it's through mental health, learning difficulties, or even physical impairments that restrict their lives, as to how much they could be undermined by families, or people that don't have good intentions towards them. That wouldn't be the experience that we have. Most family support is incredibly powerful and important. But I think, it's a really complicated question. It's a really philosophical question and would require, I think, an awful lot of thinking through.
Anyone else want to come in at all? No. Thank you.
Just to echo what Tressa said, I can't actually imagine a world where disabled people have got full human rights, to be honest with you.
Thanks, Convener.
Carol Malkin.
Thank you, Convener. My question really does relate to if the bill, was law, so I'll try to make it brief for you, and just, I suppose, ask the question around, you mentioned it actually about this as a treatment option. So I suppose my question can be quite straightforward, looking to see if you can imagine, if the bill was in place, if you feel, given the Montgomery ruling in the past about people having all these options, put forward to them as they quite rightly should have, in this case, would yourselves as disabled rights organisations find it would help with pressure in the way that you have described it, if that was not the case, that this would not be seen as a reasonable treatment option and so wouldn't be discussed at that stage? Or do you feel, again, as you expressed before, that might mean that people don't have all those options placed in front of them? And if I can say, if the bill was enacted and it was the law, how would you feel about that? If we start maybe with yourself, then.
Right, sure. So our members don't feel that it's a treatment option. For them, treatments are palliative care, it's medication, it might be physio, might be, to make them comfortable, pain, support, etc. So they didn't see this as a treatment option and they didn't want it described as a treatment option. It was quite clear that for those people that were supportive subject to, was clear that it should be the very, very, very last thing that is discussed. There should always be other options available, and that they didn't see it as either or option, either kind of thing, that these, if this bill comes through, that these would run alongside each other, that individuals require palliative care and that's their choice, and some people might be in palliative care and then make a choice around assisted dying, or vice versa, in that regard. I think it comes back to the fact that, you know, currently the assisted dying options for people, Dignitas has been spoken about, is there for people who can afford that, who can afford to pay for that, etc. And this obviously would, I'm assuming, wouldn't be, you know, paid for that equality there. But what needs to ensure happens is that if the bill comes into place, that individuals have the options available to them, but they fully understand those options. We've spoken about this, about support to understand what the terminal illness actually means for them, and that all the options available to them aren't all thrown at them at once, because they need time to process that and to put that through, but clear that it's not a treatment option, but that it's an option that people may have at full end of life, and once they've explored all the other options for them.
But in theory, that people should be aware of that option.
I think they should be aware of the option, but I think the other options, and that's what our members were saying, should be fully discussed first, etc., rather than giving all the information around assisted dying at the same time as all the other information, so that they have time to gradually process that through and have their questions that they have themselves answered as and when that they need that too.
Thank you, thank you. Mariana, do you have a view?
I think Tressa has requested to speak before I did, if that's
of course,
just to allow her to come in.
Hi there, thanks. Very quickly, I just wanted to say that what we've not spoken about, we've spoken a lot about structural barriers and inequalities, but we haven't touched on the kind of growing hostility and negative attitudes that disabled people face. And I suppose just directly in relation to the idea of treatment options, we have been experiencing more and more uncaring attitudes across health and social care and in other areas. And with limited resources and capacity to deliver services, it's no wonder that people feel frustration and extreme stress and anxiety at their work. But we're very concerned that in these circumstances, normalising assisted dying as a treatment option would further desensitise people who would not just normally be working to prevent death, but actually to enhance life and to make people's lives better. So we're really concerned about this being seen as a treatment option.
Can I ask you, and I know, given what you've said throughout today's session, I absolutely understand. I suppose my question is, if the bill was law, would you feel that your organisation would find it helpful if this wasn't discussed at all, or that people did have the right to have that option placed in front of them in terms of the way in which they discuss their options?
So if the bill was law, then obviously they would have that right. It wouldn't matter what I felt or what my members felt. I think that, as Lynn said, if the bill became law and it was an option, then it should be the last option rather than something high up the agenda. But we would much rather that the bill wasn't law. And somebody asked earlier, I think it might have been yourself, how would you feel? Terrified. Absolutely terrified. And I say that as somebody who, when diagnosed with MS 35 years ago, and I'm very lucky and I've done well, although I do experience a lot of different things that you can't see. I thought that assisted dying would be something, it would be like the last, absolute self-determination, the greatest exercise of autonomy and choice, and give you control. at that end of life stage. Having now worked with disabled people for 30 years, I am terrified at the thought of it, and I'm not thinking about myself as a very empowered and privileged disabled person who more likely will have access to information and supports and services maybe, but actually I'm thinking about my members, and there's no guarantee that I would either, but I am genuinely thinking about the people that don't have a voice, that can't speak for themselves, that can't agree, that will experience coercion and pressures and all these influences that we spoke about. So the answer to that is that I feel absolutely terrified about it.
Okay, thank you. I don't, Marianne, if you want to come in.
Yeah, that's great. I don't want to repeat what Lynn and Tressa have said, other than just to say I would echo that. I think I would also, just picking up on what Tressa said there, as disabled people, we often have multiple comorbidities, and quite often it's very difficult to get treatment for one part of your medical condition, because it's assumed that it's something, you know, so you may present with one thing and it's assumed that it's linked to your existing medical condition, and other things and other comorbidities can be missed, and disabled people don't necessarily get the treatment that they need or that they're asking for. And I think it would be really difficult to ensure that it's not presented as an option and people are pushed towards particular options, like Tressa said, the coercion that may result in it. We already see as disabled people that we can be pushed towards particular options. There is denial of medical treatment. There are people who are denied treatments that work because they're so expensive, and so we wouldn't want to see that, you know, that would become an option on the table at the expense of other options that would treat the conditions that people have, even if that's a terminal illness, to allow them to continue to live with their terminal illness. And one thing, you know, because I think we seem to have skipped over a wee bit about the coercion part of it. One of the issues within the bill about, you know, people seeing their GP, people struggle to see their GP. They struggled before the pandemic. They struggle even more to see their GPs. Most GPs are not seeing people face to face. It's telephone appointments and so on and so forth. So how are GPs going to have any meaningful relationships with their patients going forward? Because many disabled people have not been able to see their GPs for some years, and even now when they're quite ill are not being able to see a GP. So how can they be building a relationship? How would they know whether or not there's any coercion in the family? How would they know whether there's any sort of coercive control going on in those particular situations? And GPs have told us that they already feel that they are not in a position to determine that at this point, never mind at a point where someone might be asking about assisted dying. We also see that there is there's no public health policy in relation to disabled people who need hoists to access screening programmes. So many disabled people actually become ill with cancer because they can't access screening programmes. So way down the line, preventative measures are not in place to prevent disabled people becoming terminally ill. And it does seem a bit difficult at the moment to be discussing end-of-life care and, you know, assisted dying for people, including disabled people, when we can't actually even get preventative measures in place. You know, GP surgeries have, you know, we've not been able to find any in Glasgow where any GP surgery has a hoist to be able to support someone to have an examination. We've got disabled women who've not had smear tests for over 20 years because they can't get a hoist. One of our members died recently because the cancer, the female cancer she had, wasn't picked up, despite the fact that she was repeatedly telling different people in her life about the symptoms that she had. So we do have to think about preventative care at the same time, and we don't seem to be having those conversations. So I think that's why disabled people are so worried and so scared that if you put all the energy into assisted dying, where's the momentum to be able to fund and resource and promote preventative measures for disabled people? We don't see any of that at the moment.
I don't have any problem.
Thank you. Jo Fitzpatrick.
Thanks very much. Bearing in mind that all three of our witnesses today have said that they fundamentally don't support the bill, this question might not be one that you have much to say on, but I was wanting to ask about the conscientious objection and the clause within the bill around that. And So just to hear your views on whether you think that the bill is clear enough and, or should it go further, and any thoughts around institutional objections where an organisation could say we're not going to be part of this. Lynn.
When we discussed this with our members felt that it could reduce the number of terminal diagnoses made by doctors who were against the bill, so not wanting to say this is a terminal diagnosis, want to wait and put that through, and that could result in individuals not having all the information that they need to fully discuss full treatment, etc. with regards to it. Our members were also clear that individuals, medical professionals, should have the opportunity to, I suppose, opt out of being part of this. There was discussion, though, that if this comes into place and as training of medical professionals become more widely known, it may become part of the norm, and then individuals who are training to be medical professionals may not get the option of kind of opting out, and they felt that for a lot of people who've gone into the medical profession, they are there to support people to live well, to be healthy, etc. And we understand, especially those that are involved in palliative care, are there to help that end of life be a process as easy as possible and as calm as possible, but that they may still not wish to be involved in this. And I felt that was important, that was clear, that at any point in time medical professionals can stay out of that.
Yeah, thank you. Anyone else wanting to come in?
If I could make a really quick point, if that's okay, it's just to say that our concerns, we obviously support palliative care doctors who've made it quite clear that they would, and majority of them would not wish to administer medication, and a huge percentage of them have said that they would leave the profession. And our concern is that doctors with a conscientious objection would actually leave the profession, and those remaining would be more likely to be supportive of assisted dying, and that would shift the balance of doctors being pro and for assisted dying, and that would further compromise the doctor-patient relationship and eroding trust in the medical profession, and that would make it even more difficult for seriously ill patients to trust the very people that are there to support you when you're at your most vulnerable.
Thank you. Okay. Thanks, Convener.
Thank you. And Paul Sweeney.
Thank you, Convener, and thanks to the members of the panel for their contributions so far today. A key part of monitoring the appropriate implementation of assisted dying would come in the shape of the reporting provisions set out in the bill. So just want to ask members of the panel, are the reporting and monitoring requirements as drafted in the bill currently suitably robust to pick up on any potential misapplication of the law? Do you have any views on the provisions currently?
Is it okay to come in on this?
Yes, please do.
Yeah. I think that we obviously don't support the bill in a matter of principle, but we have some comments in relation to some practical things. For example, that death certificates should report that an assisted death took place. There are no socially economic elements to record whether someone had any financial difficulties prior to seeking the support and services, and similarly in relation to social care and palliative care, and what their main reason for opting for assisted dying was. And I think our main concern is there's no monitoring reporting of whether or not the person's had a mental health care assessment, any counselling or support before they've made this decision and gone ahead with the decision to end their life.
Thanks very much.
And I think Tressa wants to come in as well.
Please do.
No, I didn't have anything to add to that. I just would echo everything you're saying, Marianne.
Great, that's great. Any comments?
It was the one area that we ran out of time in our focus group to actually really spend a lot of time talking about. However, our members were clear that the reporting can't be a tick box exercise, that there needs to be someone looking at that, there needs to be the support, as Marianne and Tressa have indicated as well, to ensure that people are making that informed choice, and that we're also looking at some members felt the bill written was assuming that there is no current abuse or neglect towards disabled people happening, and therefore that needs to be really clear that the disabled person's voice, whether they are under a guardianship order, power of attorney, have learned disability, are still listened to regardless of what other individuals who may have the legal power to make a decision for them are saying, so that they are absolutely heard.
Thanks very much. That's really helpful. I do know that the English bill does stipulate that a review should include an assessment of palliative care services, which seemed to be roughly what you were suggesting, Ms Colby, so certainly something we can maybe look at. I'd just really like to conclude by asking, would the witnesses support a sunset clause to the legislation? I know there's a reporting requirement within 5 years, but would a sunset clause and or a statutory review period shorter than 5 years following the legislation's entry into force be something you would favour? Is 5 years too far out for you, or what's your view of the timescale? If you don't want to comment, it's fine, but no strong views about the 5 year period, or...
I think there's, just going back to your previous question, there's no indication of an independent review body and how much scrutiny powers they would have in relation to the bill. And I think we'd need to see much more about that before we would see something in relation to a review of the whole bill in itself. Does that make sense?
Yeah.
So there's no independent review body in relation to how the bill's been implemented from the beginning. So I think that waiting 5 years before anything's reviewed seems to be rather long, but ultimately we're opposed to the bill, so it's not something that we would wish to comment on further.
Okay, we can certainly note the point about an independent review. The obligation is on the Scottish Government to review and report to Parliament, so if we can maybe take a view on who would be the best place to conduct an independent review as well. But thanks for that feedback. That's helpful. Thank you.
I'm Brian.
Thank you, Convener. The panel have spoken very passionately, very eloquently about the lack of rights, if you like, for disability community. They've spoken very eloquently about the concerns around the impact that the bill would have on the disability community, and they highlighted, I think, very much how society at the moment is not necessarily giving the services to the disability community that they deserve and they should have the right to have. There is a flip side to that as well, and I wonder whether almost devil's advocate, if you like, in that if you have an objection to the bill because of the way in which society is treating the disabled community and the way in which you feel that the disability rights will be eroded, what about the rights of those people who, as my colleague Sandesh Gohani highlighted, maybe are suffering in the way in which I think the bill is intended to address, and that long-term suffering, who are looking to go to Switzerland or whatever to access that in the end of life option. Is there not a case here where, in protecting disabled rights, we are eroding the rights of others?
I think, so on paper, protecting one group means that the rights of others may not be upheld. Absolutely, can't dispute that. But for what reason then do we have the Equality Act with our protected groups? It's to protect those individuals because they face constant discrimination and the rights being taken away from them in all aspects of life, not just about this one area. Individual people have a choice to make with regards to things, but we don't have free choice all the time as individuals. There's laws that we need to uphold. There's certain criteria morally that we just wouldn't go against in that regard, and that may mean that for some people they can't express their rights. Right now, disabled people aren't able to express their rights to treatments, to education, to housing, to work and training, to life at times. And I'm sure that we can all give lots and lots of experiences of where rights are taken away and non-disabled people don't have those rights taken away. They're not excluded, etc. And what we're saying is that because of that, because society is geared to be against disabled people, bearing in mind every single person could become a disabled person at any point in time in their lives, but society is still geared towards the non-disabled people. We need to look out for those that are classed as more vulnerable in society. And unfortunately, that may mean that choices need to be made. And for some people, that means that their choice is taken away. Right now, none of us have the right to assisted dying. So we're already, for those people who go to Dignitas or who are positive for that, we're already eroding their rights if we look at it at that point. What we want to do is make sure that those individuals who are facing a really vulnerable time in their life are as protected as possible to make the choice that they want to make. And right now, our society is geared towards not allowing disabled people to really be heard, to make their choice, and to already, if they are against that, we've heard GDA members, GSIL members, and some Disability Ecology Scotland members who said they're against that. And already it feels like, well, that's because you're disabled people and everybody else has the right, because apparently there are more non-disabled people in the world than there are disabled people. And we know that's true, but we also know that every individual will age, could have an accident, and or develop a terminal illness and become a disabled person and part of that community.
I think Teresa wanted to come in on this point as well.
Yeah, I think Marianne had her hand up first. Is that okay if Marianne goes first?
Okay, thanks, Teresa. I think that it's our firm belief that any assisted dying legislation would further erode the rights of disabled people and cause more harm. Nobody wants to see someone suffering and in pain at the end of their life. We're not completely heartless. That's not what we want. What we do want to see is properly resourced, properly funded palliative care for people who are at the end of life. It is absolutely abhorrent that palliative care is not funded by the state and that it's relying on the third sector and charities and people having fundraising drives to fund palliative care. We don't have a right to palliative care in this country, and we don't have a right to independent living. We don't have, human rights for disabled people. And for many people who are actually choosing to end their lives via Dignitas, for example, if those rights were in place, then they might not actually choose to be ending their lives, because many of them are not terminally ill. And as I said at the beginning of the session, many of the people who are pushing for this are actually people who are disabled people who are not terminally ill. Those tend to be the people who are the faces of the campaigns. So for the very, very small amount of people who have a bad death, for want of a better phrase, it doesn't seem right to put legislation in place to make it easier for a majority of people to end their lives through assisted dying, when actually we don't have the legislation in place to make sure that everybody has the right to palliative care, the right to independent living, and the right to have their full human rights upheld. And that's our firm belief. As we've said, disabled people are already living the lives that supporters of this bill fear. And we need to make sure that our lives as disabled people are valued, and actually we get the support that we need as disabled people, but also people who are dying and who are at the end of their life get properly resourced palliative care without question and without waiting for it.
Thank you. And Teresa, did you have anything to add to that?
Yeah, just a variation on a theme. I mean, it's what Marianne and Lynn are both saying about human rights. are things that we all have, the protections that we all have because we're human beings. It's a minimum standard of how everybody should be treated, and disabled people just don't have that. We don't have dignity, we don't have autonomy, we don't have freedom, we don't have equality, all of those things. And I know that we do have protections in the law, but there is such a massive implementation gap, coming right back to 1949 for the Universal Declaration of Human Rights, right to the UN Convention on Rights of Persons with Disabilities, the Human Rights Act, the Disability Discrimination Act, all the different pieces of legislation. So as Marianne says, we are compassionate and we completely understand that people who might sit on the opposite end of the fence or the table from us are looking for upholding people's rights just the same way that we are. But unfortunately, disabled people just don't have access to all of those rights at the moment. And I don't think it should be an either or a race to the bottom. I think, as Marianne says, if services were invested in and palliative care was better funded and resourced, then people would have access to better end-of-life care.
Thank you. Can I thank all the panel members, both Lynn in the room and Teresa and Marianne online, for their evidence today. Next week, the committee will continue its stage 1 scrutiny of the Assisted Dying for Terminally Ill Adults Scotland Bill with 2 further panels of witnesses, and that concludes the public part of our meeting today.